Good afternoon. My name is Susan Lynn Osterly. I'd like to welcome everyone to the 14th convening of the Low Value Care Task Force. Before we get started, as always, we have some housekeeping to go over. First, we'd appreciate if you could add your affiliation to your Zoom name. You click the participants button at the bottom of your screen to open the list. Hover over your name and click on the More drop-down button, and then click Rename. Please include your first and last name followed by your affiliation, as shown in the example. And then we always want these meetings to be as interactive as possible. When you have a question or you want to make a comment, please raise your hand. You can click on the reactions button that's listed at the bottom of your screen and select Raise Hand. Or if you don't see a reactions button, it might be under More, and you'd have to click on that to get to reactions or possibly participants. Cliff will do his best to call on everybody in the order the hands were raised. When it's your turn to speak, please remember to unmute yourself and turn on your camera. We'd love to see you. After speaking, please lower your hand, turn off your camera, and mute yourself again. Thank you so much. And now it is my pleasure to hand things over to Mark Fendrick.
Thank you, Susan Lynn. Good afternoon, all of you. Good morning to some of you, maybe a lot of you. It's remarkable to think that we're convening the Low Value Care Task Force for the 14th time. When Mike Chernew came to me with this idea that value-based insurance design could not move forward unless we figured out a way to offset the incremental added expenditures on the high-value services that we're trying to convince public and private payers to cover more generously, we had no idea it would turn into an important part of a national movement to identify, measure, and reduce services that at best don't make Americans any healthier, and in some situations actually create harm. And as we continue to look, and we've talked about it the past few meetings, also adding to the disparities problem and worsening equity. Jordan, can you go to the next slide, please? Or there we go. So I just was looking last night to think, like, what's happening in the world of low value care, and it's so great to see some of you, I think, reported to me that you've been at all 14 meetings, and the interest in low value care reduction has grown, as you see, in a near exponential fashion. This is a surrogate to that, in just looking at the number of articles in PubMed that have low value care mentioned explicitly. So this is a low bound, and you could see that when Mike convinced me that I had to become a low value care guy, there was very few articles published in the peer review literature addressing low value care. We launched the VBID Center in 2005, the Low Value Care Task Force a few years after. Mike, Dean Smith, and I published The Role for Low Value Care and Value-Based Insurance Design and Health Affairs. We were blessed to some extent from a gift from the heavens in the fact that 6 months after the publication of that paper, the Choosing Wisely program launched. And I believe that Daniel Wolfson's leadership and the ABIM Foundation really put that mark in the ground around 2011 and created a real discussion around low value care in the United States, and many of you have participated in that. I think as we move forward in 2023, and I'll tell you in a second when our next 15th convening is in 2024, some of you, if not all of you, might know that the Choosing Wisely initiative at the ABIM Foundation has closed their doors. And those low value care lists that were generated by over 60 professional societies have now been left to those societies themselves. There is no single depositor of the low value care work, although several of us on this call are trying our best to keep the less is more movement, which I attribute that little ditty to Dr. Redberg, moving forward. So next slide, please. So as always, we couldn't convene if it wasn't for our fabulous external sponsors. This meeting is sponsored by Johnson & Johnson Janssen. We're very appreciative to all the work they're doing in the high and low value care space, as well as pharma, which is understanding that to be able to move forward their cost-effective and high-value interventions and innovations, there needs to be some break somewhere, because if total cost of care is price times volume, and we at the VBID Center have had little to do with issues of pricing outside of out-of-pocket costs, volume should certainly be divided into volume good things, which we want to subsidize, as well as lower the spending and utilization of volume bad things. So this is really, as Brian Agnew said at meeting number 1 of this task force, is that to create headroom for public and private payers, which many of you represent organizations in that space, it would be certainly easier to use those savings on reducing low value care than putting in blunt barriers to high value care use, such as deductibles, which many of you know keep me up at night. So next slide, Jordan, please. And the last slide for me before I'm so happy to turn it over to Cliff Goodman, and you'll all be happy to get rid of me for a while. So if you haven't already, which I don't think we've announced this, the next convening, number 15 of this task force, is going to be at the same time, 12 to 4 East Coast time on Wednesday, April 24. So I hope you'll all put in your calendars. For those of you who want to present updates on your work in low value care to the group, let me or Susan Lynn know, and we'll make sure you get a spot on the agenda. Next slide, please. So some things change, but some things stay the same. And we are incredibly lucky, as for the 14th time, to have my very close friend and colleague, Cliff Goodman, to moderate today's program. And with that, with great thanks, Cliff, I turn it over to you.
Thank you very much, Mark. I'm honored to be here, and look forward to not only the 15th, but subsequent task force meetings. Let's go to the next slide, please. And here you see our agenda. It's pretty packed, but it's got some great presentations lined up. In a moment, we're going to do a few introductions of people that are new to this call, and then we'll have a few member updates, I think. Then we're going to go to a talk by Ilana Richmond out of Yale, who's going to address the decreasing unnecessary cancer screenings and overdiagnosis. And I'm reminded to commend to everyone the great article of which she was the lead author in the Annals about overdiagnosis of breast cancer. And I think she's going to touch on that. She'll be followed by Anna Snieko from Harvard, who's going to address translating low-value care research into action. So what does the research tell us about what we need to do next? She'll then be followed by Allie Oakes out of Trilliant, who's going to address reducing low-value care starts by understanding its drivers. And I've had the good fortune to see Allie's presentation, and there's a lot of stuff that she's going to pack into that with regard to the various drivers and their interrelationships. We'll take a 15-minute break, after which we're going to have a fireside chat with Cheryl Damberg out of RAND. And of course, I think she's recently appointed a new commissioner at MedPAC, and we're going to try to get her research angle as well as her MedPAC angle on that vis-a-vis low-value care. She'll be followed by Kristen Paulson out of Colorado, who's going to talk about best practices and challenges in addressing low-value care, and she's going to draw on some very practical and successful work that she's pulled off. She and her team have pulled off in Colorado toward that end. And then I'll turn it over to Mike Chernow for any next steps, final words, and adjournment. So that's what we're going to try to pack in here today. From now to the bottom of the hour, I'd like to do the following. We'll start out with some introductions to some new folks here. And I'm going to start with Mike Ingham out of Janssen. Mike, tell us what your connection is to this topic and what you see with regard to low-value care and reducing thereof.
Hi, thank you very much. I'm actually sitting in today on behalf of my boss, Silas Martin, who some of you may have known or met. I'm sure you have. And just so you know, my role here is actually I've been involved in health economics research for 30 years, and more recently in terms of policy research. So a lot of what we're doing now is related to issues such as this, mostly in the high value care component, right, to improving high value care, but also in looking at policies and the impact of policies. A lot of our current work is around equity and discussions around issues of equity with current benefit designs. So I think that a lot of our interest around the low value care is specifically around groups such as this, like our sponsorship of groups of this, wanting to get that information out. I think even seeing Mark's chart about a growing number of publications, I think we still feel it's not high enough. There should be a lot more discussion on the idea of low value care. So it's part of our interest in terms of sponsoring groups such as this. And so it's really around that idea of how do we get more information out there about low value care, because we think, as you have stated in your mandate, is that could help pay for future, if there is waste in the system, or if there's ability to reduce low value care, that could pay for future high value care, which is of interest to us.
And thanks, Mike. The low value care sort of opportunity to create headroom for new and better stuff is always there. And I would imagine that even a company like Janssen, part of J&J, you want your stuff used when it ought to be used and when it's indicated for proper use and not other circumstances, I would guess.
Right. Correct.
Thank you, Mike. Let's move on to Louis Jacques. Louis Jacques is the senior consultant at AbbVie. He'll tell you about that in a second. And he has a distinguished past with CMS and coverage and analysis. Louis?
Thanks, Uncle Cliff. And I'm going to be retiring from AbbVie at the end of March. So this is sort of part of my going back to my roots. I did run Medicare national coverage at CMS from 2009 to 2014. For the 5 years before that, I ran one of the divisions within coverage. And it's through the MedCAC that I know Mark and Cliff and Rita. I am also a Medicare beneficiary. So I have a significant interest in low-value healthcare, much of which consists of telling my own doctors that I refuse to do certain things that they reflexively do because they are either in guidelines or something else. And then I have to explain to them the evidence that supports, in fact, not doing anything. And I'd like to get to a different place. I used to have a saying, every crook has a congressman and 2 senators. I was a federal witness in the bribery trial of a sitting U.S. senator on issues, frankly, related to low-value healthcare. So I come at this from many directions, and my interest in this actually is different than my current work, but it's a personal interest.
Louis, would you care to opine a bit on, now that you're a step or two away from your role at CMS, what sort of perspective CMS and Medicare in particular might have vis-a-vis low value care, and any efforts to kind of limit it?
I mean, CMS has tried over the years to do various things. And, for example, on never events, there were NCDs on never events. And personally, I didn't support those things because writing an NCD around a never, it's not like someone's going to intentionally cut off the wrong foot. So you're applying, in that case, I think, the wrong tool. I was also reminded several times by our government attorneys that Congress created the quality program to improve the quality of healthcare, and that is not the purview of the coverage program. So I think Congress and the various people who influence Congress have done a good job of keeping the federal government so siloed that it's hard to find any comprehensive government effort. There's usually, well, this agency wants to do this, but it's stymied because this other agency doesn't think they have the authority to do the thing you need to do, and on and on. I mean, how many conversations are, gee, if only FDA would do X, and FDA says, oh no, we can't do that. That's not in our ballpark. So, I come here as a frustrated advocate.
Well, there are a lot of discussions about the relative roles of FDA and CMS, and they grew out of different purposes. Their statute had very little to do with each other, and it doesn't seem that either one is directly involved in limiting low-value care, certainly not FDA, except for safety issues, and CMS for whatever falls under reasonable and necessary and falls outside of that, which is always a tough call. But in any case, Louis, great to have you on today. We really welcome you. Thank you very much. Also want to recognize Sarah Bitter. Sarah, you've kind of accompanying longtime participant Rita Redberg, but we'd like to hear any perspectives you might have to bring to us, Sarah.
Yeah, sure. I can talk a little bit about the work we've been doing over the past year. I say we, but I joined the team full-time at the start of the summer. So I'm still relatively new. But yes, we've been continuing our work on research on the evidence for low-value medical devices. As well as on the policy side, we've been collaborating with Louisiana Medicaid to try to make their coverage policies more evidence-based for a variety of low-value procedures. And also, we also submit public comments to CMS, for example, for the recent proposal on the transitional coverage for emerging technologies and other proposed rules.
You're in good position to do that. Now, I know you said you're rather new to that particular outfit, but you did mention medical devices, Sarah. Mm-hmm. Do you have any particular example or insight you've gained thus far regarding medical devices and low-value care? Anything to which you might want to call our attention to, if not now and in the future? Nothing like
The
putting you on
answer
the
is
spot.
the answer is yes. I think my medical background is loaded, so that's where I would be faltering a bit. I think our work about a year ago on spinal cord stimulators, I think in JAMA neurology, and sorry if I'm blanking overall, but yes, there's lots of room for reducing low value care in medical devices.
Yeah. Well, we're looking
Right.
forward to that. A lot of the action has been on drugs, but certainly there's some important instances with devices. And creating the headroom for devices is just as important because devices keep coming and evolving quickly. So that headroom is something to look forward to. Rita, I see your hands up, and then I'll go over to David Kim. Rita.
I was just going to add to what Sarah already shared with you that specifically in Louisiana, the devices we're looking at are stents, coronary stents, PCI, because there's a lot of potential to reduce low value care there, as well as peripheral arterial revascularization and sinus balloon plastic. And there are lots of other devices we'd like to, maybe we'll talk about later, but mechanical circulatory support devices come to mind, particularly if we're going to have conversations about various innovative coverage policies like coverage with evidence development.
Yeah, it all ties in there. And it's good to hear at some future point, we may want to hear more about what the relationship is between you and the state of Louisiana and how that's operating. But thanks, Rita, and thank you, Sarah. Great to have you. David, you got your hand up. I'm going to call on you for two reasons. One, anything you wanted to add based on what you just heard, and then any update you want to offer from out Chicago way.
Yeah, so I think thanks for having me again. And then for those who didn't participate last meeting, that I share kind of my research work on the lesson learned from low value prostate cancer screening, highlighting that U.S. Preventive Service Task Force guideline itself is not so effective in the long term to reduce the low value care. There are substantial state level variations we identified. And then also I highlighted this, cascade care, which is a subsequent healthcare use initiated from low value PSA screening was pretty substantial. And then $1 spent on the initial PSA screening actually came back with $6 additional related to the subsequent, PSA related services. So in our research team, we continue to expand our work. So we in this phase, we try to focusing on two things. One is understanding racial differences in the receipt of low value care among Medicare beneficiary. And then one particular focus is that we try to focusing on within healthcare system. Basically, we try to get rid of those system level factors. And then if you go to the same hospitals, MGH or U Chicago Medicines, then because of your characteristics, whether you're less or more likely to receive low value care. So that's the one thing we try to examine. Second thing, I think the Mark briefly touched on his initial remark, but we're really interested in measuring harms associated with the low value care. And then we try to measure harms in the three ways that looking at the patient outcomes. So for those like low value inpatient cares, we try to measure the hospital acquired conditions, patient safety indicators, and then readmissions, and then obviously the mortality caused from the low value care. And then obviously similar things that we did for low value PSA screening, that we try to look at unnecessary subsequent cares and then overall wasteful spendings triggered by the initial low value services. So stay tuned, and then whenever we're ready, I'm happy to share the updates to this group. Thanks.
Well, that's a good update right now. And I think at some point we'll come back to you for a more detailed look at that. Just one quick question, Dave, before we move on. And that is, you mentioned low value care and matters of equity and so forth. Can you give us one little hint about either an example or some other insight you've had recently about how low value care relates to particularly underserved populations and those who experience traditional disparities?
Yeah, so I think the disparity in the low value care is actually a little bit mixed. So I think the key question is that whether we all know the disadvantaged populations receive less care, and then whether they receive less of high value care and low value care. So I think the questions that we're trying to understand is really, they just receive overall less care, regardless of the value of the care. I think the overall evidence shows align with that side, but we try to dig a little bit deeper.
Aha. Well, there's certainly a lot on that issue to tease out. Gosh, there's just so much to learn about that relationship in particular. And David, I hope that in a forthcoming task force meeting, we'll have you drill down more on that as your findings evolve. Thank you very much.
Sure. Yeah, happy to. Thanks.
That's great. Beth Bortz, do I see you on the line? I want an update out of Virginia. Beth?
I'm here, Cliff. I'm
There she
always
is.
here.
Thank you.
So quick update from Virginia. In terms of our Smarter Care Virginia initiative that was funded by Arnold Ventures, the active intervention period has concluded. And the good doctor, John Maffei, is now leading the evaluation component of that work. And we have promised to have that complete by June 30th of 2024. So we should have a report back to you. As you can all imagine, the evaluation is a little bit more complex than we had anticipated in 2019 when we were awarded the funds, given that we had a pandemic in the middle of the intervention. So John has his work cut out for him, but he is hard at work with Kyle Russell at VHI in sorting through the data. The second thing I'll share with you all, if you haven't seen it already, is we did conclude the 5th Starfield Summit, which was held to talk about how we could best address primary care and low value care, how we bring those two groups together. And so there's a full report if you're interested on both my website, and if you just go search Google Starfield Summit, you can pull up the report from the 5th proceedings. The last thing I wanted to share is we actually just on September 20th in the Commonwealth convened our board and leadership council, which includes about 50 different organizations from kind of all parts of the healthcare system, state government, public, et cetera. And we talked about what we were going to do next related to low value care. And it was a very interesting discussion. A lot of the discussion focused on how do we make the juice worth the squeeze, if you will, that there was concern that, the numbers are just too small. And Mark and Mike and I have talked about this at length, that tends to be the challenge. The direction that they have indicated that they want to go is in our increasing our ability to do practice level and NPI level total cost of care reports, where we start to identify the key cost drivers. We've done a state level total cost of care report, but now they want us to get it in the hands of frontline clinicians so that they can see what the key drivers of cost are. The other piece that was kind of reiterated by many folks was that if we did a better job of getting clinicians to be in a place where they could assume risk, that alone would help them make better choices about how they choose high and low value care, if they were responsible. So the idea was really more about how do we move people into risk-bearing contracts? How do we get them prepared for that so that then they have their own incentive, as opposed to having external incentives placed on them, that they have their own incentive to make better choices. The other piece, we did review data. We had reports done for us on low value care pharmacy, as well as waste, fraud, and abuse through machine learning. So we reviewed that data. Both very interesting, but again, both small percentages. And so that's why that conversation about juice worth the squeeze keeps coming up. I will close with saying where the group thought perhaps the most juice is in a discussion of tackling site of care. And so, that's an area where it's a hot topic. I mean, people feel very strongly about it, but it's one that we are going to have more conversations about in the Commonwealth.
Well, Beth, one of the best things you just illustrated and that you've done since the beginning here is you've continued to maintain close contact with basically all your stakeholders. And so you give them feedback, you interact with them frequently, and you just gave 3 or 4 types of direct feedback, including juice and being worth squeeze and so forth. But the aspect of education, awareness, and the placement of incentives as means to achieve reducing low value care and increasing headroom for high value care. So that's kind of, if we're going to design a way to do this right, maintaining that kind of ongoing contact with your stakeholders really makes a difference. So thank you, Beth.
Absolutely, Cliff. And I would just say, to echo that, I think the constant in our work has been that, we assume that people are coming to the table with the right incentives, and our job is to give them the data to help them make better choices.
Point well taken. Thank you, Beth. That's great. Just a heads up for later now, Mike Chernow, at the end of this, we're going to call on you for some overarching remarks and observations. So Mike, I hope you're going to be getting those queued up for toward the end of our afternoon. We're on time to move next to our first presentation, and this is going to be, and you see it there, Decreasing Unnecessary Cancer Screenings and Overdiagnosis, from Ilana Richmond. I'm going to kind of show you, if you can see it. Ilana, I read your swell article in the annals on this, and really like your methodology and the way you've expressed the findings. And I hope that you'll do same within the next 30 minutes to include about 20 presentation, 10 or so for Q&A. But Ilana, you're on, and great to have you.
Thank you so much for having me. I'm going to go ahead and share my screen.
Okay.
Okay.
It's on.
All right. Great. So thank you, Mark and team, for having me. I'm a general internist at Yale. My research interest is in cancer screening, including thinking about overdiagnosis. And today I'm actually going to take a broad view of thinking about low value screening in the breast cancer world in particular. I think, breast cancer screening in many ways is a microcosm of other kinds of screening and preventive services. And my goal really is to illustrate some of the lessons that we've learned along the way, because I think they're not only important for a service that's provided for, millions of women across the country, but also more broadly across preventive services. So to begin, we'll start from the premise that screening mammography for women in the typical screening age range is high value care. But I'm going to talk about 2 common sets of scenarios where a high value service like screening mammography can become low value. One instance is when we move from a technology like mammography that we know to be cost effective to newer technologies that may offer small benefits, but come at greater cost. So the adoption of low value technologies. And I'm going to give a specific example that we'll take a bit of a deep dive on, called digital breast tomosynthesis. Another example, a kind of common scenario where a high value service like screening can become low value is when we move from screening populations where there's good benefit for the buck to ones where there is no benefit or small benefit. And here I'm going to talk about screening older women as an example. And in both cases, I'll try to illustrate sort of where we are and perhaps give some ideas about where we ought to go. So I mentioned that screening mammography constitutes high value care. When I say that, what I really am referring to is this kind of typical health economic definition where when we compare women who are screened to not screened, we get some incremental health benefit. We reduce the risk of dying of breast cancer for a certain cost. This is an old cost effectiveness analysis from 1995, JAMA, that shows the incremental cost effectiveness ratios on the right-hand side were under a typical willingness to pay threshold. I think it's worth just reiterating that that screening mammography and most kinds of preventive services for that matter are not cost saving. They cost something, but we think it's worth it. And conversely, when I talk about low value care, at least especially for the first half of the talk, I'm not necessarily talking about a service that's harmful, but maybe one that doesn't provide good value. Okay, so that cost effectiveness analysis, 1995, grainy table from an old journal, really looked at the first iteration of screening mammography, but technology has come a long way, right? We had film mammography, and then we moved to digital. We added computer-aided detection. That was like early AI to identify areas of potential abnormality. We added supplemental screening with ultrasound or MRI for women with dense breasts. Then we moved to digital breast tomosynthesis, which I'll talk more about in depth. And then, coming down the pike at 1,000,000 miles an hour is AI for breast cancer screening. So we'll focus on digital breast tomosynthesis as kind of a deeper dive and a case study. So what is tomosynthesis? So tomosynthesis is an imaging modality that uses multiple X-ray exposures to actually reconstruct a three-dimensional image of breast tissue. It's kind of like other sorts of computed tomography, like if you got a CT scan of your chest, for example. And the idea is that you can better identify areas of abnormality and normal breast tissue by taking slices rather than looking through a single 2D image. And so, even a lowly general internist like myself could see that there's an abnormality here that was obscured on the 2D image. What do we know about tomosynthesis? Well, most studies have looked at short-term outcomes, and it seems pretty clear that tomosynthesis is better at finding small invasive breast cancers than 2D mammography. So the incremental cancer detection rate is a bit higher. And also fewer women are called back for abnormal exams, so the recall is lower. But we don't have long-term studies to show that tomosynthesis improves morbidity from breast cancer or mortality, although there is work underway. This study looked at the cost effectiveness of tomosynthesis, again, thinking about, all right, maybe there's some small short-term benefit. How does that translate into long-term benefits, knowing that it'll take us 20 years to figure this out? Can we model it? So these authors used gold standard simulation models to project the long-term benefits and costs of screening with digital breast tomosynthesis compared to traditional 2D mammography. They used 3 different models, which are illustrated in these colors here, red, blue, and green, and found that at the typical Medicare price, which is about $57 or $58 for tomosynthesis, it was not cost effective, even at a generous threshold of $150,000 per quality adjusted life year or so. So based on this analysis, which I think was well done, we can conclude that digital breast tomosynthesis, there's some incremental benefit, but it's not worth the cost at current prices. That definitely hasn't held us back. And I think what's remarkable about tomosynthesis use is that it's really been a sea change in how women are screened for breast cancer. So this graph depicts the proportion of women in a large privately insured population that we studied who are using tomosynthesis. 2015 was the first year that it could be observed in claims. There's a CPT code. And then through the end of 2019, we looked, so beginning in 2015, about 12% of women were screened with 2D, and then the other 88% were screened with 2D. And then over time, that's completely reversed, where the majority of women are now screened with tomosynthesis and the minority with 2D alone. And we would see that almost all women in the country are being screened with this newer technology. There's really been a real revolution in how women are screened. So, why is this? Like, why have we totally converted to this newer technology despite questions about its value? I think there are a few reasons, which I'll illustrate here. We asked questions about each of these. So greater reimbursement, state level policies that potentially encourage adoption, marketing, and local culture. I'll talk a bit about each of those, and then some of the other factors I think influence adoption. So here we used claims from a large private insurer to ask, well, what about reimbursement? And we found that essentially, even when you account for the fact that using tomosynthesis might mean fewer women come back for subsequent imaging, typically the reimbursement for the episode cost for tomosynthesis is about 25% higher than for women screened with 2D. And that's illustrated. The light blue line here is women screened with digital breast tomosynthesis, and then the dark blue is 2D. So you can see there's a difference in price of about 25%. So, look, I am a physician. I don't think physicians respond only to financial incentives, but there's of course also evidence that we are human and do pay attention when there is an incentive, and so this may be part of the reason for adoption. There have also been state level policies that have encouraged adoption. So a number of states around the country have required first dollar coverage without cost sharing for tomosynthesis, and we asked, what is the effect of those policies? And so here's the pre-adoption period and the post. And in the post-adoption period, we saw about a 9 percentage point increase in the proportion of women screened with tomosynthesis. So, it's modest, but may contribute to broader use. What about the role of marketing? So in this study, we asked whether radiologists who have a financial relationship with manufacturers of tomosynthesis are more likely to use it. And yes, radiologists who took payments that were specifically related to tomosynthesis were in fact more likely to use it, illustrated by the dark black bars here compared to radiologists who didn't. And interestingly, even radiologists in practice with others who took payments but didn't personally take payments were more likely to use it. And that's in these dark black bars here. So, marketing, may play a role in adoption. And then lastly, culture. So this is a look at early adoption of tomosynthesis, where we looked at local patterns of adoption. You can see that there's clear geographic differences. In the Northeast and New England, the Mid-Atlantic states, the Pacific Northwest, there was really brisk adoption of tomosynthesis compared to the South, where there was much slower adoption. And what is it about the local culture, a microclimate, where some physicians want to embrace the latest, greatest, and others are more conservative in their practice? I think it's hard to say, like we need an anthropologist maybe to answer that question, but there's clearly something about the local culture that influences adoption. But I think all of those things are not the whole story. Radiologist enthusiasm, I think, plays a role. And it's not totally misplaced in my view. Like, there are potential advantages to tomosynthesis, right? Maybe we find more cancers. Maybe over the long term that matters. I think the argument that fewer women get called back for false positives is actually compelling. And so I think this idea of sort of professional opinion has played a role, and it maybe is not totally crazy. Particularly thinking about the idea that tomosynthesis may reduce the need to come back for false positives. And lastly, I'll just point out this idea of choice architecture. So on the right is a picture of a tomosynthesis machine. It looks just like a regular mammography machine. It has the compression plates and the X-ray device and all that. And when a woman comes in, the experience is very similar to having a 2D mammogram. And this can sit right in the place in the office where the mammography machine used to be. And so when you have a technology that can replace the status quo without being disruptive, it's easier for her to just slot in and become the default. And so I think, again, this idea of these sort of structural factors supporting adoption has been powerful. So what can we learn from this experience in terms of the adoption of tomosynthesis, which we know is not cost effective, but has become widely used? So first of all, I think it's not one thing, right? It's multiple factors. It's culture, it's reimbursement, it's marketing, it's potentially policies, it's expert opinion. All these things can conspire to spur rapid adoption. Technologies that can integrate seamlessly into the status quo are likely to be quickly adopted. And I think this in particular has broad implications when we think about AI. AI is not even a physical thing, it's just a software, right? And so it's easy to integrate it. Patients don't even know that it's happening. You don't have to go and do anything different. And so there's real potential for rapid adoption. I think we're thinking about the experience of tomosynthesis and what it means for future technological change. Another point is that constraining use is hard, right? This cost effectiveness analysis is published now almost 4 years ago. And, despite there being important questions about value, nothing has changed. If anything, we've continued to rapidly adopt tomosynthesis, and influencing any of these one particular things is difficult. And then also a question whether constraining use should be the goal. Like I'm generally a conservative person, and think we ought to have information about the long-term outcomes, but also we have to balance that with the potential value of innovation. I recognize that you can't sort of wait around 20 years always to know if something is going to pan out. And so we have to balance those two things. And thinking along those lines, if it's difficult to constrain use, what other levers do we have? Well, there's the price, right? Thinking about the value, maybe there's only a small incremental benefit. So it's not that we shouldn't use it, but we should be paying less. So if DBT, for example, costs $30 instead of $58, then we would end up below the incremental cost effectiveness ratio, and we'd have a high value intervention instead of a low value one. So how do we get to a lower price? I think, the typical ideas, we could set a price that we believe to be value-based, based on cost effectiveness modeling. I think in this particular instance, thinking about episode payments or bundle payments or other kinds of flat fees for an episode of screening is potentially valuable, right? Because this is in some ways not just about tomosynthesis, but what do we do about supplemental screening? What about integrating AI? All these technologies, there are a million decisions to make about all of them. But if we say, all right, for breast cancer screening, radiologist gets paid X, and within that, they can decide, all right, where is the value? What technologies will reduce false positives? without generating additional cost, maybe that's the right technology to choose. So it leaves discretion in the hands of physicians, but without incentivizing a particular technology for which we don't have strong evidence. So that's a bit about DBT, again, focusing on ways in which technological change can happen. Now I'm going to shift gears and talk about the kind of other instance of low value care in breast cancer screening. That's when we have what we think is a high value intervention, high value screening, but it's applied to a population where the potential benefits are smaller or non-existent and the harms are greater. So what do we know about breast cancer screening among older women? Well, our current guidelines recommend screening for women who are 50 to 74. Probably shortly we'll recommend screening for women 40 to 74. The guidelines are not draft, but will be likely finalized. But the U.S. Preventive Services Task Force guidelines make no strong recommendations for or against screening women 75 and older. And that is because none of the large trials that inform our current guidelines have included women over the age of 74. There just aren't data from large trials in this population. But in spite of the lack of guidelines and lack of trial evidence, that hasn't held us back, as usual. These are data from the National Health Interview Survey, nationally representative data that show that women over the age of 75 are commonly screened. So in the past 2 years, more than half of women 75 and older reported undergoing a screening mammogram. So it's really commonly performed. So even in the absence of trial data, it doesn't mean we have no information about the benefits and risks of screening older women. This was an observational study published in the Annals of Internal Medicine a few years ago that used Medicare data to try to parse out the risks and benefits of screening. And these authors found that when women in their early 70s continued screening, the cumulative risk of breast cancer mortality was lower. That's this solid line here compared to women who stopped screening. That's this dashed line here. And so there's probably benefit for women in their early 70s. But when we look above that, women 75 to 84, these two lines overlap. And the authors concluded that there's no benefit, at least in terms of breast cancer specific mortality with continued screening above the age of 75. So that would mean that in this age group, moving screening from younger women to older women is not only low value, it's no value. We did work that Mark mentioned, looking at risk of overdiagnosis. What is overdiagnosis? It's this kind of fascinating phenomenon where through screening, we find cancers that never would have been clinically apparent otherwise. So these are cancers that potentially grow slowly and would remain dormant or otherwise go undetected in a person's lifetime. But once we look for them on screening, we find them, and then we're typically obligated to treat them unless we have other paradigms for surveillance or watchful waiting. But in breast cancer, we usually treat them. And that means that some women end up getting treated for breast cancers that never would have caused symptoms and certainly never would have been life-threatening. Of course, whether overdiagnosis impacts the value of screening depends on how common it is. If it's 1 in a million, we can ignore it. But if it's common, then it means that women are being potentially harmed by screening. And so we use data from Medicare claims linked to cancer registry data to estimate overdiagnosis, and found that for women over the age of 85, about half of breast cancers found on screening are potentially overdiagnosed. And even among women in their early 70s, we thought it was about 30%. So this is pretty common among older women who are screened. All right, so what about value? This was a cost effectiveness analysis of continuing breast cancer screening for women 75 and older. And these authors looked at a few different strategies: annual mammography, biennial, different age ranges, 80, 85, 90, and different levels of comorbidity, and then concluded that annual mammography is almost never cost effective, but biennial mammography could be cost effective continuing from the age 75 to 80, even for women with moderate comorbidity. I will say that these authors assumed there was some benefit to screening, in contrast to that other observational study I mentioned, and they had relatively conservative estimates of overdiagnosis. So of course, if you assume that there's no benefit to screening, it's not going to be cost effective in any context. And if you assume the harms are higher, even with moderate benefit, we may no longer be in the cost effective range. So I think, even optimistically, above the age of 80, screening is not cost effective for most women. So what do we do about this? What is the solution? How do we reduce low value screening among older women? So we could think about policy levers like guidelines. Should the U.S. Preventive Services Task Force give this a D recommendation? Don't do it. Should we say we're not going to cover screening for older women? These options are potentially effective, although I think, changing guidelines often doesn't change physician behavior that much. And I will say we're doing some qualitative work with older women, and the payment policy ideas are deeply unpopular, even without asking older women about it. Many older women have volunteered that they really would be disappointed if insurance companies made decisions about whether they ought to receive mammography. So, potentially effective, but deeply unpopular. Where we think there's an opportunity is really around patient-centered care and shared decision-making. So there's some great work by a geriatrician at Hopkins named Nancy Schonborn, who's done deep qualitative work talking to older patients about stopping cancer screening. And one of the themes that's emerged from her work is that older adults are open to talking about stopping cancer screening, especially in the context of a trusting physician relationship. Like, people realize that there may be limited benefits to continuing cancer screening at an older age, but they want to be part of that discussion. Like, we all want to have our autonomy respected, and that's no different, I think, for older adults facing decisions around cancer screening. The second is that shared decision-making may be valuable, and there's trial data to suggest that incorporating information around overdiagnosis can help people understand this complex and sort of strange phenomenon. And then also using decision aids, structured shared decision-making for older women can be effective. And I'll highlight some work by Mara Schonberg at Harvard. So Mara is a colleague who's interested in using decision aids to help older women, navigate decisions around screening. And this is a screenshot from a decision aid that she developed. It's a structured tool that lays out the risks and benefits of screening. So here you can see it talks about women like you who continue to get mammograms, 3 out of 1,000 will die of breast cancer. And if you stop, 4 out of 1,000 die. So women can understand that 1 per 1,000 may benefit from breast cancer screening. And it goes on to present similar data in absolute terms for the harms of screening. The idea behind a decision aid is to present balanced information, not to lead anybody down a particular path, but really to lay out the decision and the risks and benefits of various options. And what Dr. Schonberg and her colleagues found is that when they tested this decision aid in a randomized trial, women who were exposed to it were less likely to choose screening, about 9 percentage points lower. And so what's powerful to me about this is that decision aids are not strong-arming anybody into anything, and on the contrary, they're really laying out options and allowing people to make an informed decision. But the outcome of that decision in this case was in line with delivering higher value care and having more women opt out of an intervention that's probably unlikely to help them. And so I think in many ways, this is a potential win-win. All right, one last thing about decision aids, which is that implementation is the challenge. I'm a primary care doctor, and there's like a million barriers to using these. There's no time, there's other priorities, they're not integrated into clinical workflows. But there are solutions to this. Like, we could integrate them into the EHR, into clinical workflows. We could set aside dedicated time and reimbursement to go through these kinds of tools. And we could also use other team members to engage in this kind of shared decision-making. Okay, so in summary, we start from the premise that breast cancer screening with mammography is cost-effective, but there are common scenarios where it can become low-value care. For example, when we introduce new technologies that may have small benefits in comparison to the cost, or when we move to screening populations where the benefits are attenuated or null. But there are potential solutions to these common situations. So for example, thinking about how do we reimburse for new technologies? What is the value-based price? Or can we think about other kinds of reimbursement strategies that don't favor implementing a specific technology? And then second, thinking about using screening in populations where the benefits may be smaller or null, how can we, rather than tell patients unilaterally they shouldn't be screened, how can we engage patients to make decisions that end up being both high value and in line with a patient's goals? So thank you, and happy to discuss.
That's great, Ilana. Thank you very much. And I'm glad you covered both the DBT and the overdiagnosis aspect. Just before, I'm going to go to Rita Redberg in just a moment. Can you please make sure everyone understands the relationship between overdiagnosis and inaccurate diagnosis? And I think some of our clinicians out in the field may have trouble with that. I think they're either slightly intersecting Venn diagrams or definitely distinct in the Venn diagram.
Yeah, thank you. So there are two distinct entities. One is that can occur after breast cancer screening or any kind of screening, really. So one is a false positive, and that's a situation where it looks like there's potentially a malignancy or an abnormality on the image, like there's a shadow, there's a mass, but it turns out that actually everything's fine. It's benign. That's a false positive. That's in contrast to overdiagnosis. Overdiagnosis is a situation where there's an abnormality on the mammogram. We get a biopsy. The biopsy, in fact, shows a breast cancer, but that breast cancer never would have become clinically apparent had we not gone looking for it. Like if we had just never done the mammogram, we wouldn't have known about it. The person never would have had a mass or pain or metastatic disease or any other symptom, and just would have sort of lived out the rest of their life in blissful ignorance. And so those are really two, I think, distinct harms of screening: false positives and overdiagnosis.
So it'd just be interesting in the field when if we try to kind of raise awareness and do education on this, clinicians as well as payers may have a little trouble kind of in their decision making along those lines. They are distinct concepts. Absolutely.
Yeah. And I will say, like, as I mentioned, we're doing some qualitative work about how to integrate overdiagnosis into patient-centered decision making. It's very hard for people to understand. And frankly, even when they understand it, it's not totally clear how it influences decisions. Like we've had women say to us, yes, I understand you can have a cancer that would remain dormant and never would cause harm, but I still want to know about it. And so I think there's this tension between this sort of desire to know and this sort of paradigm that it's always important to get that mammogram. And then what is the reality of like what that information actually tells us or how it impacts health outcomes?
Great point. Great point. I want to go to Rita next, followed by Carol Huffman. Rita?
Thanks, Cliff, and great talk, Ilana. I think breast cancer screening is a really good topic but it's so, as everyone knows, very politically sensitive. I mean, the data, and you talked about breast cancer mortality and how there was a very small benefit on mortality. As I put in the chat, the work shows the systematic review that was published in JAMA Internal Medicine a few weeks ago showed there's actually no benefit on all-cause mortality. And so I think when women say they want to know, it's because they think they're actually going to live longer. So a lot of the problem is that we have never been clear, and the tagline for mammography is, mammography saves lives, and the data just does not support that statement at all. So, which kind of brings us again back to coverage and CMS. Right now ACA mandates that mammography is covered, or anything with a grade A. I'm glad Louis turned his video on. Grade A and grade B has first dollar coverage. And not only that, things that don't fall in that, like the over 75s are still covered. And so when women, shared decision making could work if anyone did it, but the problem is that nobody does it. And when mammographers, I can tell you, every time we published an article in JAMA Internal Medicine that suggested, for example, just sticking to the task force guidelines of every 2 years as opposed to every year, which the radiologists recommend, the radiologists were just, up in arms. And the suggestion that it was because they had any financial interest in it, they said, no, it was only that they care about women. So this was a way of saying, I think that we really have to think about and changing coverage and not covering things that are clearly harming women. And although I think, as I said, there's very questionable data from mammography in general, certainly at the margins, the over 75 and the 40 to 50-year-old women, I mean, I don't think we should be covering those at all. Only the older group is Medicare, the rest is private payer. And I understand that that's very politically sensitive, but
it is.
Really, there's so much harm, and I'm interested in others' reactions.
Thanks. And we did see Louis' comment about political pressure from Congress. Just a few minutes left. Go to Carol next. Carol Huffman.
Yeah, so what a great topic. And first I'll say that I've spent the last couple of years on women's health. And this summer, we did this timeline with a couple great interns. Mark's seen it. And we tried to say, okay, let's take an example of a woman's life from birth till death and figure out what is it, what are the milestones, and what are the things that a woman needs to be thinking about and doing as far as their psycho and social health. And when the interns finished, they finished at age 65. And then one of my friends said, geez, Carol, I feel like we're almost, like it's the end, and I said, yeah, I know, we're not dead yet. So we pulled it out to 100. And what my response to you in this conversation is, it needs to be a much bigger conversation than screening for mammograms after a certain age, because what we're seeing is that people, you have to think about what do they want, right? And not, the healthcare system has been great at trying to do things to people, and really we have to change the conversation, particularly with women, and say, what do they want and why? And
Yep.
so when we make it part of a bigger conversation, we're saying these are the things that are going to most likely impact your quality of life now, and your quality of what you do now will impact your quality of life when you're 80 and 90 and 100. So here's the conversation that we have to start much earlier around the why behind we're recommending things, and the clinicians really do have to be front and center, but there has to be a much bigger initiative to talk to women about, this post-menopause period, and what is it that's really going on, and what screenings and what are the things that will really impact a better quality of life. Until we get to that point, we're just sort of dealing with these silos around this screening or that screening. And I think that, people are much smarter than that. And I think women are really chomping at the bit to understand this. And so we in the healthcare system really need to step back and say, how else can we have a conversation around women's health, especially in terms of those post-menopause years?
No kidding. Point well taken, Carol. Thanks very much. Louis, 30 seconds because we've got to move on. 30 seconds, Louis.
Yeah, I mean, I think women are not a homogeneous block. My mother-in-law is nothing at all like any of the women on this call. My mother-in-law had screening colonoscopy at age 88, because her gastroenterologist said, why don't you get one? And she said, of course. So women are very different. It's not like one size fits all.
Yeah, thank you, Louis, very much. Well, Alana, you certainly stimulated quite a bit of conversation. We don't have time for more questions at this point, but I see that people know how to get in touch with you, and I've seen in the chat how to get one or more of your articles. So, Alana, thank you very, very much. Great contribution. Really appreciate it.
It was a pleasure to be here. Thank you for having me.
Our pleasure as well. Thank you. Let's now move on briskly to Anna Sinyanko from Harvard. And she's going to address translating low-value care research into action. And I might note that she actually is going to share with us some tools, basically, about how to do this well. Anna.
Good afternoon. Hello. I want to thank Mike and Mark for the invitation to be here this afternoon and to present some of my thoughts about translating low-value care research into action. I'm going to share my screen. Here, can everyone see that?
Yes, it just came up.
Okay, great. Thank you for confirming. So I am an assistant professor of health economics and policy at the Harvard Chan School of Public Health. And I do research on how policies that change information or incentives in healthcare affect access to care, affect quality, and affect spending. And so today I'm going to talk about some work I've been doing around the topic of healthcare prices and variation in healthcare prices, and how when we pay higher prices and don't get higher quality for those higher prices, that's effectively low value care. And so thinking about things that we can do to try to move patients away from those low value, high price settings into other settings. So I'm going to start just by showing some data, which I'm sure is not a new concept for everyone here on the call, which is that there's wide variation in healthcare prices within markets here in the US. This is just one chart to demonstrate this concept. This is from Massachusetts, and it just shows the different paid prices for a low complexity gastric bypass surgery in 2021 across facilities in Massachusetts. And you can just see the range from $35,000 at the high end down to $21,000 at the low end. And there's variation both in the facility paid amount and the professional component in the orange. So this is just one of many. There's this pattern holds across the US. This pattern holds across inpatient services, outpatient services, et cetera. So we know that we have these wide variations in prices. And the concern is that when you pay higher prices for equivalent quality care, that's low value, right? We could get more for our dollars by moving to a lower price place, getting the equivalent quality, and then we would have leftover money to spend on other things that matter or to save. And so when we think about intervening here, like how can we address this source of low value care? There's sort of two questions I want to address. One, what factors increase the use of higher price care? And two, what interventions could help steer patients away from higher price and lower value care providers? And I'm going to take these in turn and tell you about some research that I've just completed over the last year to help answer these questions. So first, the first project I'm going to tell you about is one we did in Massachusetts, looking at vertical consolidation. And so vertical consolidation is when physicians and hospitals or health systems that own hospitals either become jointly owned or contract together, and in a way where they're negotiating shared rates. And over the last decade, we have seen this form of vertical consolidation in healthcare increasing. So the proportion of physicians that are either owned or contract with hospitals and health systems with hospitals, is dramatically increasing. And along with this vertical consolidation, what we're getting is higher physician prices. We did a study in Massachusetts where we looked at, as physicians either become owned by health systems or joint contract with health systems, what is happening to paid prices. And the findings is that the prices go up for these physicians for their office visits. Physicians in medium-sized systems saw increase in prices of about 7.7%, and in large systems, the price increases were 12%. And so what's going on is, as a result of the consolidation, there's likely an increase in market power for these physicians that is leading to higher prices. But this is only one way that we're seeing that vertical consolidation is leading to higher healthcare prices or paying higher healthcare prices. So the other way is that consolidation is also increasing the steering of patients into health systems, moving care from lower price to higher price, say, hospital settings. And so as a continuation of this work, also in Massachusetts, we looked at what happened to patient flows of care when the patient's PCP was acquired or started to contract with a health system. And we looked at their flows of care for specialist visits, emergency department visits, and hospitalizations. So in this work, the first question we asked was, did their overall use of these visits change when their PCP became vertically related or went through vertical consolidation with the health system? And on the use question, we saw that specialist visits increased by about 22%. So after a patient's primary care physician became vertically consolidated with the health system, specialist visits increased. We saw no change in emergency department visits and no change in hospitalizations, which perhaps is quite a good sign, right? There's no increase in use of these higher acuity care just because your PCP has a new ownership relationship or contracting relationship. But then we looked at, well, where were they having their specialist visits, emergency department visits, and hospitalizations, and found that the use of this care within the PCP's new health system increased. So specialist visits inside the new health system went up by almost 30%. Emergency department visits, even though there was no change in the total number of ED visits, the share of those ED visits that is now in the new health system went up by 14%. And similarly, the share of hospitalizations in the new health system went up by 22.4%. So we're seeing flows of patients moving into these health systems. And so we were curious, what is the impact on spending and on readmissions, which is a measure perhaps of care coordination or higher quality care, and find here that the result was higher spending with no change in readmissions. And so if you look, this is a table from the paper, but if you look on the far right, here circled in red, essentially the total medical expenditure per patient per year increased by just over 6% following the PCP's entering an ownership or contracting relationship with the health system. And the probability of admission to a high price hospital went up by almost 5%. And then below that, we looked at readmission rates and probability of admission to a hospital with a low readmission rate, and there was no statistically significant effect, suggesting that we're essentially steering patients into higher price settings, without, at least on this measure, gains in outcomes. And the literature on the quality changing quality associated with vertical consolidation is, I would say at best, equivocal. There's not overwhelming evidence that vertical consolidation is improving quality, suggesting that we are paying higher prices without a lot of improvement in quality or outcomes. So this sort of raises, at least in my mind, that we really do need strategies to steer patients to lower price care settings. And there's a few, interventions or ways that we might do this in the market. One is the use of high value provider networks or reference-based pricing. Both of these are forms of benefit design where patients pay different amounts out of pocket for care received at a low cost versus a high cost setting. So you pay less if you go to a low cost setting. It's an incentive to get patients to do that. And I'm not going to talk much more about these two today. I do research on these topics though, so I'd be happy to talk later at any point with folks if you're interested. And today I wanted to think about prescription drug formularies, which essentially try to do the same thing. Place drugs into different tiers of a formulary and give patients financial incentives to choose a drug in the lower tier or the lower cost tier. And essentially that rewards patients for choosing a lower price drug. Now, all of these, and especially the prescription drug formularies, require information about relative price differences for patients, so patients can make informed choices, right? It's hard to choose the lower cost setting, even when you have an incentive to do so, if you don't know that you have the incentive or you don't know the price difference, the money that you'll save by choosing the lower cost setting. And so I'm now going to turn to focus a little bit more about how much could you save by choosing a lower cost or preferred tier drug. And it varies, but for several drugs, out-of-pocket costs vary and are high. And so one of these types of drugs that I was going to show as an example today are SGLT2 inhibitors for diabetes. The out-of-pocket costs for SGLT2 inhibitors are generally high, but they vary by drug within this class. This is just some data showing how much the patient copay can vary for the different types of SGLT2s for patients with commercial or employer-based coverage. And so you can see that not only do the range for each drug is quite varied, And that's because it depends on the patient's plan, right? The different SGLT2s are preferred in different patients' plans. So it varies for patients across health plans, and often, or at least to date, a lot of this information was unknown to patients and clinicians when they are prescribing these drugs. So it's difficult for patients to choose the lowest cost SGLT2 inhibitor without information about their actual out-of-pocket cost, should they have one prescribed and go fill it. So I think there's a case for clinician-facing medication price information, and particularly, I mean, patients' out-of-pocket cost information to help patients choose lower cost drugs. And I didn't say this on the prior slide, but I think an important point here is that within the class of, like, say, SGLT2 inhibitors, there's equivalent quality for the most part. And so that a lot of clinicians would be comfortable prescribing any of the SGLT2s and helping the patient find the one that's the lower cost for them, and then might also have the lower total spending because of its preferred formulary placement, would then be higher value care. So clinicians have enormous influence over patients' cost pressures because, in effect, with their prescribing decisions, they're choosing which drugs patients will take, and with those come out-of-pocket costs. When you ask clinicians about, cost of care for their patients, they report feeling a moral obligation to help patients afford their care and their medications. In fact, clinicians already do a lot of this work to help patients find lower out-of-pocket costs, but it's often burdensome. Requires back and forth with the patient, requires back and forth with the pharmacist, and takes time. And so there's an opportunity, perhaps, if we gave price information to clinicians at the time of prescribing, to avoid some of that burdensome work. And then, as I mentioned, incorporating out-of-pocket costs into prescribing decisions could improve not only patient affordability, but value if it also moves patients from higher price branded drugs to lower price equivalent branded drugs. So we did a study recently looking at real-time benefit tools. These tools are embedded in the electronic health record, and they are intended to give price estimates of a patient's out-of-pocket medication cost at the time of prescribing. And so the clinician would type the medication into the order screen here on the left. And this is a depiction of Epic, but these tools exist in other EHRs as well. And so they type the order in, and then when the ordering screen comes up, they have two options. At the top, they could click the estimate button to learn the patient's out-of-pocket price estimate, or they could go to sign the order. And what's interesting about these real-time benefit tools is they can be configured so that if a clinician goes to sign the order and there's an alternative medication available that is lower cost for the patient and equivalent, then there will be a pop-up. And the pop-up looks something like this. It essentially shows an out-of-pocket cost estimate for the medication initially chosen by the clinician, that's on the top, and then the suggested alternatives underneath. And the clinician, in theory, can either accept the alternative and order the suggestion, they can reject it and order the initial selection, or they can close out of the order and start over. And these tools are relatively new. And in the last few years, Medicare policy has been released by CMS to increase their implementation. And so there were two series of new Medicare policies. The first, that as of 2021, there's a requirement that Part D plans have, with at least one contracting health system, access to an RTBT. And then as of 2023, a requirement that Part D beneficiaries have access to information from an RTBT. So I think the implementation of these policies is still a bit of a question, but certainly there's support from Medicare for this technology. And so I think the first question we sought to learn about is whether these real-time benefit tools are changing what clinicians are ordering for medication. And we did a study of a large health system, the University of Colorado Health System, where they implemented a real-time benefit tool, and price estimates were displayed via alerts, so pop-ups when the clinician was ordering during about 10% of orders. That's the solid green line, second from the bottom, and more frequently for some other medication subclasses. So more frequent pop-ups for cardiovascular medications, antihyperglycemic medications, and psychotherapeutic medications. And pop-ups were really driven by the prices of the drugs and whether there were substitutes. And so when we looked at these data and whether following a pop-up clinicians changed their orders, we found in primary care that clinicians changed their medication orders more when the potential savings for the patient was greater. So move on the left, you can see a chart showing data using from asthma medications that overall about 12% of the time the clinician changed their medication order, but when the potential cost savings for the patient was over $20, they changed their medication order almost 20% of the time. There was a similar pattern on the right for cardiovascular medications, and a similar pattern for diabetes medications, but we looked at psychotherapeutic medications and we did not see this price response. We saw that with psychotherapeutics, clinicians were not more likely to change their order with price increases. I think suggesting that there are probably clinical considerations around switching psychotherapeutic drugs for patients that are very important. This we just published in JAMA Internal Medicine as a research letter. And so just to wrap up, what's next? I mean, real-time benefit tools, are they a new intervention that could really help patients and increase value in the healthcare system? We do start to see here some evidence that clinicians are responding to out-of-pocket price information and changing their orders when out-of-pocket costs for patients are high. So perhaps helping patients find lower cost medications for their care. We know that 29% of patients with a prescription report some cost-related barriers to taking those medications. And so could these RTBTs change medication adherence and spending and health outcomes? That would also improve value. And then also I think there's important implications for equity and disparities that we're interested and we'll look into, in particular because patients who live in rural areas and patients who are Black and Hispanic report higher rates of cost-related non-adherence. If we make medications more affordable and help clinicians help their patients find lower cost drugs, we might actually improve equity and reduce disparities in medication adherence. I think there's some important questions, though, about these real-time benefit tools, which is how to maximize their benefit without exacerbating alert fatigue among clinicians. And there's a lot to learn about best practices for their implementation and use, and also about the accuracy of the suggested recommendations of alternatives. Can they be improved so that we really are giving clinicians a simple signal about how to help their patients find lower cost medications without too many pop-ups and exacerbating what we know is a real problem in alert fatigue. So I'll stop there. Thank you very much.
Well, Anna, thank you very much. We have until the bottom of the hour to take a few questions here. And I see Scott popped up right away. Scott Weingarten, followed by Denise. Scott, what do you have?
Yeah, no. Hey, Mark, Anna, fantastic work. Just a comment on the 80 to 90% of the time, the clinician rejected the suggestions. And could you talk a little bit about that? How could we get, higher adoption rates, and what the overall cost benefit might be, even at 80 to 90% rejection, and whether we think it was worth the alert fatigue that it caused?
So I think that is, I've wondered the same very question myself. So, right, 80 to 90% of the time in the primary care population, we're seeing that the physician or clinician ordered their initial selection, what they wanted to order from the beginning. And in some follow-on work that we're just starting to do, we're seeing slightly higher rates of accepting changing orders for patients with chronic conditions who are on more medications. I think the important thing here is going to be, how do we focus this intervention in the instances where there really are opportunities to switch medications that are equivalent quality without, and where there are high costs, and without having pop-ups for all of the everything else, right? And so we haven't been able to do a calculation like you were asking, what's the return on investment yet? That's kind of in the works. And we're also going to go out and talk to clinicians and patients in this system to try to understand what the experience is like, which I think might also inform how do we improve this technology, right? So we really can get the most that it can offer without the adverse consequences.
Good response to an insightful question. Thank you, Anna. Let's go next to Denise Giambalvo, and then we'll get to Mark Fendrick. Denise, what do you have?
Hey, I'm more of a comment than question. I love that you've done this research and you're heading down this path. I think it's a sad commentary to the system that we've built and what's going on in pharmacy benefits. In a past role that I was in, we sent letters to the patient, letting them know that there was a less expensive drug that they could be receiving with same or higher efficacy. And that same letter went to the physician. And then they were able to, to share decision-making and make the change. And if we didn't see a change happen within 6 months, we would continue to send letters to both. Hey, there's an opportunity for savings. Something else, just, for consideration, and that is in plan design. We also worked with the employers. So even if there was a share in cost versus a flat copay, right? So when you get into specialty drugs, it's often 1%. There's still a cap where the patient never pays more than X, whatever that X amount, whatever is appropriate for that. And again, this is on the employer side, employer population. So just some other things for consideration. We did provide a tool for providers where they could access that patient's formulary and see what they would pay. It was a low percentage of usage, kind of along the lines of what you were seeing. So
thanks very much, Denise. Good point, and a lot of helpful feedback on how you kind of need to continue to tweak this. Let's go over to Mark Fendrick next.
Thanks, Cliff. I'll try to be quick. Anna, your work is a gift to me personally and this group. It's there is a very key bullet in one of your slides about physicians having enormous influence in decisions that patients make. There have been all these efforts to have patients be the actual purchasers and consumers, and Mike and Zach Cooper Chernu have done amazing work that patients generally follow what their clinicians do, even if they go into medical debt, which we know is very common in this thing. So this real-time prescribing is a great step forward. And for those of you who are not following the incredible conversation in the chat, that's really rose my hand. It's really remarkable. And I'll respond to my close colleague, Lauren Vella, who's always worried more about the than about the patient, which is what we have focused on in the VBID world for decades. And she mentions a lot about alternative methods like copay cards that may actually lower the price for the patient lower than what your real-time prescribing might say. What I'll say to that and put in the chat is the good news is Mike Ingham and I have published a paper saying that the use of copay cards is equal among affluent and underserved populations, which is very, very surprising. But unfortunately, these copay accumulators, which try to put copay cards under check, were actually put in place more for underserved populations than for affluent ones. And we were very pleased to see recent legal decisions overturning these accumulators. But keep up the amazing work. And Lauren, I'll say to you, Americans don't care about healthcare costs. They care about what it costs them. And we rely on experts like you to actually have the grown-ups in the room, like the people who make the drugs and people who buy the drugs, hopefully take the patient out of the equation so they could get the care they need.
Thanks very much, Mark. And we all agree there's a very, very rich conversation in the chat box, which is worthy in and of itself. Also want to acknowledge Jordan Clark for posting in the chat various links to Anna's articles and so forth. We really appreciate that. Anna, I want to give you a final word here. Great presentation. I tell you, the thing that scared me was the vertical consolidation stuff. This is like, I'm not sure if it's market failure or a new kind of market, but it decreases competition, increases price and costs, increases steering, didn't have a change in readmissions. There's a whole market potential failure going on there. Maybe it's more moving towards monopolies or what, but that's a bit scary. And I just wonder, that's maybe counterproductive for low value care. In any case, any final comments from you, Anna?
Yes, I agree. There's a lot of things going on in what I talked about. So I know it was a lot in 20 minutes.
It was great.
But I do want to say, just on following up Mark's point about, clinicians make decisions. Patients actually want to talk to their clinicians about their costs. They're happy, when you ask them in surveys, who do they want to talk to find affordable medications? Often their clinicians. So I think that's a nice thing about this as well.
That's great. Anna, thank you very, very much. You two have prompted a lot of feedback, and I think you're going to get a lot of hits on those swell articles. We really appreciate you being part of our program today. Thanks very much.
Yeah, thanks for having me.
You got it. Okay, we're going to move on to more exciting stuff. Next up is Allison Oakes out of Trilliant Health, and she's going to take a look at reducing low value care starts by understanding its drivers. It has a really good kind of clear breakdown of the drivers for low value care. And it'll be interesting to see the extent to which she also picks up on some points made earlier today. So Allison, you are on.
Thanks, Cliff. Hi, everyone. Pleasure to be here. I will go ahead and pull up my presentation. Before diving in, I will also echo that I'm curious and worried about all that vertical consolidation as well. I think it'll be really interesting to see how that plays out. And I think that quality piece and how we understand care coordination is a really interesting component of it as well. So are you able to see my screen okay, Cliff?
We can. It's right
Perfect.
there.
So with that, I'll dive in. And as Cliff was saying, I'm going to be focused on the topic of identifying and addressing drivers of low value care. In terms of the agenda for today, first I'll provide a little bit of motivation for employers and payers in terms of why we should care about low value service use. I'm then going to focus on the two sort of variables that go into our healthcare spending, utilization and price, and then we'll wrap up with some final thoughts. So as I'm sure many people on the call are familiar, in 2021, US healthcare spending reached $4.3 trillion, or about $13,000 per person. And as a share of total GDP, health spending in the United States accounted for about 18.3% of our spend. And most alarmingly about all of this is that while we spend more money on healthcare, we have worse outcomes and health than many of our other developed peer countries. And while these numbers are big and can oftentimes seem abstract, they really do have practical implications for each one of us. So in these next couple of slides, I take the perspective of the employer and the employee. And most of us are one of those things, and some people on the call are both of those things. So looking at the graph in the bottom left of this panel, we see that the share of employees covered by a high deductible health plan has grown from 4% in 2006 to 29% in 2022. And as Mark and Anna were just commenting on, the real implication of these high deductible health plans is that it's putting individual people on the hook for more dollars that they spend. At the same time, looking at the top left, we've seen that these deductibles have also increased over this period of time. Specifically from 2010 to 2022, we've seen that deductibles have increased by more than 30%. So people are also increasingly on the hook for more of their healthcare spending. By 2022, the average deductible for an individual was $2,500, and for a family, it was just below $5,000. Further insult to injury, looking at that final figure on the right, we see that the amount that people are contributing via their premium has also increased consistently for more than a decade. So in 2009, on average, people were spending $3,700 on their premium, and that has increased to almost $6,000 in 2021. These financial effects are felt by everyday people and are really unsustainable. However, more than ever, I think that employers really have the potential power to start to bend these cost curves and go to bat for their employees. Why is this? If we look at the employer-sponsored health insurance market, we see that that market alone accounts for 25% of all U.S. health expenditures. So in my opinion, that's 25% of the market that has a clear interest in reducing costs and increasing value. I think that armed with the right data and the right measures, employers can begin to move the needle on utilization and spending, ultimately increasing value. And that phrase, increasing value, is what brings us to the equation and the concept of low value care. So across the healthcare system, there are really two variables that are responsible for that $4.3 trillion in healthcare spending. There's utilization, how much healthcare we use, and there's price, what we pay for those given services. Taking things a step further, the concept of healthcare value is essentially the measure of what we are getting for our money. Is it a good deal or a bad deal? So if we all agree we want to decrease spending and increase value, there are two clear levers to pull, as I alluded to before. First is utilization, and second is price. For the sake of today's talk, we'll start with utilization. And kind of following this equation through, by decreasing unnecessary utilization or low value care, this in turn decreases spending while increasing quality, which ultimately would increase value across our healthcare system. As was mentioned and alluded to a couple of times earlier today, I think another really important emphasis related to reducing low value care is highlighting the opportunity cost that it poses to our healthcare system. If we're spending dollars on low value or wasteful things, that crowds out the amount of high value care that we're able to provide. So first, just a couple of illustrative examples with some back of the envelope math. And the goal of this is to get a sense of the true kind of cost of low value care. So to do this, we looked at 3 procedures or interventions that have a higher value option and the potential savings associated with switching from the current status quo to that lower cost, higher value procedure or treatment. So taking screening colonoscopy as the example, along the bottom here, we see that as it stands today, there's approximately 15 million procedures that go on annually at an average rate of close to $12,000. And this results in about $175 billion in total spend. However, there's mounting evidence that there's some lower cost options that could be equally as effective as screening colonoscopy. Those options include fecal occult blood testing, flexible sigmoidoscopy, and also fecal DNA testing. So over here on the right, we do some simple math to kind of understand if screening colonoscopy was replaced at a rate of 5% by these lower cost options, what the potential revenue loss would be to certain people, or what the potential reductions in spending would be for others. So we see that if folks switched at a rate of 5% to these other lower cost options, there would be an associated approximately $8.7 billion in spending. If we got the switching rate up to 20%, we'd be talking about $35 billion. So this begs the question of what's driving these low value care choices. Based on a kind of mounting number of papers and research that's been done, it's becoming clear that use of low value services is driven by both financial and non-financial motivations. And in my opinion, understanding these drivers is essential to developing strategies to reduce low-value care. As has been referenced a few times today, low-value care is commonly attributed to fee-for-service payment in our fee-for-service system. However, research has shown that overuse exists in non-fee-for-service healthcare systems and across insurance types, regardless of reimbursement or insurance benefit structure. So just a few examples here to drive that home. First, looking to our neighbors in the north, in the globally budgeted health system of Alberta, Canada, it was found that 30% of beneficiaries older than 75 received at least one of 10 low-value services. Back stateside, in the state of Maryland, there was a shift to global hospital budgets in 2014, and we found that that shift to global budgets was not associated with a reduction in systemic overuse, which was measured across 19 diverse services. This was a paper co-authored with Aditi Sen, who's also on the call today. And then lastly, within the VA in the United States, which is really a fascinating healthcare system and our largest healthcare system in the United States, the VA is a non-fee-for-service integrated system, and it also insulates physicians from malpractice. However, even within the VA, we see that 5 to 21% of veterans undergo a low-value diagnostic test for several common medical procedures. So what do all of these different findings around the magnitude and persistence of low-value care mean? The provision of low-value care when financial incentives are not present suggests to me that there are other motivating forces that contribute to overuse, which are likely driven by a deep-seated perception held by both clinicians and patients that more is better. And I think it's breaking down those provider factors related to the system, their knowledge, discomfort with uncertainty, and the kind of social expectations around treatment that will be integral to developing the right policies to tackle low-value service use. So in understanding the magnitude of low-value care, we've also looked at the variation in it. And fortunately, there's meaningful variation that we can potentially exploit to try and target those who tend to use low-value services. And what I mean by meaningful variation is that we see tendencies across regions and health systems related to their patterns of overuse. On this slide here, I'm showing some great work done by Ashani Ganguly out of Harvard. Here, she was looking at the level of the particular hospital. On the left, you can see she was looking across 5 different clinical categories, and the spread of these different distributions just gives you a sense of how much variation there is and how different systems or providers overuse low-value care services. Not everyone is overusing low-value care services in the same way. And over on the right from that same work, this replicates some other analyses that we've done looking at systemic overuse. Here, she's plotting the different hospitals across the United States and what their kind of level of overuse is, where red is indicative of being a high overuse hospital and blue is indicative of being a low overuse hospital. So just looking at this map begs the question of if you had to go to a hospital, if a loved one had to go to a hospital, or if your potentially many hundreds or thousands of employees had to go to a hospital, where would you want to send them? So just to drive home a few more points about this meaningful variation, we see that regional variation at the level of the market, that systemic overuse persists over time, which suggests that those clinical decisions are related to systematic differences in care delivery rather than some kind of random noise. There's also evidence about physician behavior within versus across different physician groups, which suggests that organizational culture influences patterns of low-value service use. So there's been some fascinating work by Adam Elshag where they look at the exact same provider providing care in different hospital systems, and they see that that individual provider switches their behavior depending on which system they're in, which probably speaks to the individual cultures and infrastructures and processes in place at those different organizations. Third, we also see that individuals and organizations have distinct overuse profiles with substantial performance variations that are present over time and are consistent across different types of low-value care. So using these different clinical categories on the bottom left of this slide as an example, the idea here is that if you go to a particular hospital that is likely to overuse laboratory tests, they're also likely to be overusing other things like low-value prescriptions, possibly C-sections, or other types of medications. And one other thing I just did want to flag for the group, across multiple studies, we've now seen that a higher supply of primary care providers is associated with less overuse. So what are we to do about all of this? In order to address the utilization of low-value care, I think there are two clear steps for all of us to be considering and taking. First, we really need to incorporate existing measures of low-value care as a standard component of quality measurement. And this data can then be used to benchmark and monitor organizations and providers. To date, most, if not all, quality improvement initiatives and pay-for-performance programs have focused almost exclusively on underuse. But there's this advantage to mitigating over low-value care, which benefits everyone, which is that it allows for the reallocation of limited resources towards services that actually maximize population health. On this point, I will note that having worked on the provider side and also at a very large payer, on the payer side, sometimes having those conversations around eliminating low-value care were met with, it was tough to have those conversations and to get people on board with investing and reducing low-value care. But when framing low-value care as this opportunity cost, it often kind of greased the wheels in helping to get those conversations going. So once we're reliably measuring low-value care as a standard component of quality, the next step is to develop policies and interventions that align with the motivations of patients and clinicians at the time a health service is ordered. We need to meet patients and clinicians where they are. Interventions that narrowly focus on economics or financial waste ignore the important psychological concerns and physical harms that contribute to overuse. So what are the policies and interventions that either have worked or are most likely to work? These are the three where I'm kind of hedging my bets at this point. So first, electronic health record nudges, which it was awesome to follow behind Anna and after the intervention that she discussed. So electronic health record nudges, the key stakeholder here are really health systems and providers. They're the individuals who have the ability to implement these interventions. And in terms of the process, nudges involve subtle changes to the design of the environment or framing of information that influences behaviors. These changes have a large but predictable impact on medical decision-making. One example of a nudge are default options, and these are the conditions that are set into place unless an alternative is actively chosen. And default settings have been shown to be particularly effective. Really, the underlying idea of nudges is to design things and systems and infrastructure so that the right choice is the easy choice. And one particular example of a very successful nudge intervention, this was run out of Penn Medicine and was led by Mitesh Patel. Within the electronic health record, they implemented an opt-out checkbox, which was labeled dispense as written. And if left unchecked, the generic equivalent medication was automatically prescribed. And after having done this, basically overnight, generic prescribing increased from 75% to 98% across the system, so across multiple hospitals. Really, another key feature of nudges is that when done well, the goal is that they're inexpensive and highly scalable. So moving on to that, to the second type of intervention, social norms. The key stakeholders here are health systems, providers, and payers. The reason for that being, in order to deploy social norm interventions, you really need access to data about provider behavior. So what's the process here? As humans, we can all appreciate that individuals are influenced by social preferences, identities, and norms, and social norms signal appropriate behavior. The goal of social norm interventions is to provide normative feedback about how an individual provider or hospital is performing compared to their peers. So for example, if I was a OBGYN at a particular health system, I might be told that my C-section rate is 30%, whereas the average C-section rate amongst my peers at my own hospital is only 20%. And the idea is that that should help slightly competitive people to course correct to come closer to their peers' performance. So just another specific example coming out of Penn Medicine, a peer comparison, randomized control trial was run where they were providing peer comparison feedback about the number of opioid pills that were being prescribed. And it was found that peer comparison successfully led to a reduction in the number of pills being filled in each prescription. And then finally, high performance networks. This was mentioned by Anna as well, and I think in some sense is a little bit of the holy grail. The key stakeholders here are health systems, providers, payers, and employers. The process is to measure and identify providers who deliver high value care that is evidence-based and appropriate. And I think a key here is that payers aggregate this data, but then do need to be sharing it with providers and employers. So lastly, in terms of those variables that contribute to value, there's the lever of price. And I think I would be remiss if I didn't mention it in this talk. Price and negotiated rates is also becoming particularly important with the release of all the new payer price transparency data. So here we're plotting the negotiated institutional rate for DRG 470 for a single payer United Healthcare across a few thousand hospitals in the United States. And as has been alluded to before, we see significant variation in the prices being paid for the exact same service. Specifically, we see rates range from $12,000 to $64,000, and there's a median rate of $29,000, while the most common rate, or perhaps the market rate, is $23,500. And what this data begs the question is, will employers continue paying a 5-time difference for the same service across their employee populations? As Anna alluded to before, this is data just for one DRG, but we could look at any number of procedures and would see a similar pattern emerge. As everyone is familiar, patients also don't just have isolated single healthcare encounters. They're often on a whole patient trajectory related to whatever their care needs might be. So here we're taking a total cost of care perspective, focused on an individual with lung cancer. And we kind of play out this hypothetical but data-driven scenario where this individual with lung cancer has 11 related visits and is receiving chemotherapy. And we look at what this would cost if they went to 4 different providers within the New York City market. And here we find that the lowest cost provider, the total cost of care for these 11 visits would be $70,000, while the total cost of care at the most expensive provider would be $100,000. So this begs the question of, where would you be getting the most bang for your buck? What is the highest value provider here? So part of the trouble, I think, in healthcare is understanding if high value means the lowest cost provider or if it means something else. Based on our experiences using Amazon, Kelley Blue Book, things like that, as humans, we've kind of been trained to believe that you get what you pay for. The lowest cost thing is the lowest quality thing. The highest cost thing is the highest quality thing. But looking at the health plan price transparency data, and I think probably no surprise to many people on the call today, we're finding that within healthcare, price and quality just are not correlated. So here we're plotting the negotiated rate for hospitals in the Los Angeles market for DRG 469, and we're plotting their rate against a measure of quality, specifically the excess readmission ratio. And generally speaking, hospitals that fall into this upper left quadrant are higher quality and lower price, and hospitals falling into this lower right red quadrant are lower quality and higher price. So I think the question is that as employers become armed with a combination of quality data along with negotiated rate data, how will they be able to put those things together to better negotiate on behalf of themselves and their employees? So to wrap up, the provision of low value care where financial incentives are not present suggests that there are other motivating forces that contribute to overuse, likely driven by a deep-seated perception held by both clinicians and patients that more is better. In terms of tackling this, I think the first 2 key steps are incorporating existing measures of low value care as a standard component of quality measurement. And then 2, developing policies and interventions that, again, really meet patients and clinicians where they are when they're in the midst of a medical decision-making encounter. And in terms of where I'd kind of place my bets and what has been and is most likely to be successful, I'm really focused on electronic health record nudges, deploying social norm data and interventions, developing those high performance networks based on all of this data and the new health plan price transparency data. And then finally, working on those negotiated rates to reduce some of that variation and make sure that we're getting value in terms of what we're paying for. So I'll leave it there, Cliff.
Thank you, Allie. And please do leave this conclusion slide up there, because hitting on the EHR nudges, social norms, high performance networks, and negotiated rates are quite concrete as ways of strategies here, and you support them very, very nicely. We'll be glad to take questions and Allie's answers until the top of the hour. And Allie, I must say that a term you're supporting, a term that was used up front by Alana, this thing about choice architecture and setting up the system in a way in various places, whether it's EHRs or elsewhere, to make it easy and smoother to do the right thing.
Yep.
And I think that's a persuasive concept that you've established very, very nicely. You've shown some discouraging stuff with regard to price and quality. That was not encouraging, the lack of correlation. In any case, we'll go to Mike Chernow for a question. Mike?
Yes, thank you. That was really terrific. Two sort of related questions. The first one is, what is the role of benefit consultants in guiding how employers decide which of these things to do and how to do them? And of course, these are often provider level things, and the employers don't have connections with the providers. The plans do, so the employers have to push the plans to push the providers. And the second question, which is a much more detailed one that I may talk about at the end of this meeting, is what role do you see of things like performance guarantees in the RFPs to maybe hold people accountable for doing these things, as opposed to kind of hoping they will do it? Hoping they will do it.
Great questions. Taking the first one, I don't have the legal background to be completely versed in this, but I know that since the health plan price transparency data has come out, the health insurance brokers have been in a lot of hot water. I think there are actually a number of lawsuits going on related to kind of their performance over the years. And I think sort of historically, absent this information related to price, the insurance brokers and folks kind of in that field have just kind of put forth this notion that, well, a 5 to 10% increase year over year is what you should expect. And as long as I'm meeting those goals, this is the status quo. So in a way, I think the status quo is kind of our biggest enemy with figuring this all out. So now that this health plan price transparency data is out there, the question is, and this is something we're thinking about as a company, how can we be arming the employers with some more information related to this? Because as you were saying, Mike, employers have to be making these decisions, but in a lot of ways, they've kind of been in the dark in terms of actual data. So I think a question is how we can get this into the hands of employers so they can be making more data-driven decisions and be putting some of that data to their brokers and helping them navigate things.
Yeah. So as an aside for the people listening, and you should send messages to Mark. That is so fun for me to say. We're pondering pushing more on this exact theme for future meetings, because part of the issue is the chain from the employer to the plan, with the benefit consultants in the middle to the providers. Even if the employer is having information, there's so many actors that getting to the action seems to be hard. And luckily, I see Beth's hands up. This, I think about the call on Beth, but when I want to know what employers are doing, I look for Beth to raise her hand too.
Well, thanks, Mike. Not only do we look to Beth, but Lauren Vella has made some very incisive comments about employers' perspectives here as well. Thank you.
Yeah, absolutely. And my time with Lauren at PBGH earlier this year was really outstanding. So I agree.
No surprise. Beth Bortz.
Cliff, thanks. I just, I love all of this. And I, for a long time, have been wanting Virginia to go down the pathway of sharing this kind of information to help people make choices as to clinicians. But my concern is timing right now, because at least in the Commonwealth, we're having tremendous workforce issues where it's not a question of me getting to pick and choose providers. People are concerned that they can't even find a provider, and they're going to take whatever provider they can get in with in the shortest amount of time possible. And cost is no longer a consideration in those decisions. And so I wonder if others are experiencing this. I mean, we just had research that for a first time primary care visit, the average wait time is over 20 days in Virginia. So you're not going to be going to a narrow network in that situation.
Something else we've been thinking about a little bit related to that, Beth, and I think many are, is the role of all these new entrants in this space, right? So your Walmarts, your One Medicals, your CVS, especially as it potentially impacts low value care, the duplication of services, or like kind of disaggregates that primary care pathway. How does that impact low value care? Maybe for some low acuity services, if it's known to be low cost, it's the right answer, but how do we find the balance of that? And, you know, on the hospital side, how can they be sending those sort of low acuity, low revenue things that they don't really want to be doing anyway elsewhere, but making sure that care remains coordinated? I think it's a huge question, but is probably what we're kind of up against in the coming years.
Yeah, let's
Totally
not lose.
agree. And telehealth is another piece of that.
Yep.
Telehealth. And Beth, thanks for raising the workforce issue. It's numbers and it's quality. Primary care versus specialty, that's a really important angle here, and how it has downstream impact on low value care. Josh, you're going to have the last word briefly. What do you have, Josh?
Yeah. Hey, Cliff. So one thing I just wanted to add for the state of Minnesota state employee health plan, we just went through our medical plan RFP this year, and in our TPA contracts for 2024, we do have low value care performance measures in our contracts. They're starting at $0 and just trying to develop a baseline, but hopefully down the road looking to put some of our admin fees with our TPAs at risk, depending on how they're managing low value care costs.
That's a great angle on it, Josh. Very practical in a state. A lot of folks look to that state, your state, for models of care that have worked over the years. But that's a very, it's an exceptional angle to take. Thank you. Well, Allie, any final closing remarks? This is obviously a very well-received presentation. I really appreciate how you kind of derive those final four nudges, norms, networks, and negotiation. That was much appreciated. Any final word from you, Allie?
I think it's just focusing on those four things. And the last thing I would say, which I know a lot of people in this group are focused on, is the importance of rapid experimentation. So standing up any intervention or policy takes a lot of time, effort, and money, but we want to be making sure that what we're implementing is ultimately effective. So when we stand these things up, let's make sure we're also measuring them on the back end to make sure that they're effective, don't have any unintended consequences, and that the real ROI is ultimately there.
Points very well taken and substantiated. Thanks, Allie.
Thanks, Cliff.
Okay,
thanks, everybody.
You got it. In a moment, we're going to take a 15-minute break. And when we come back, we're going to have a great kind of fireside chat with Cheryl Damberg, who, as I said earlier, is a newly appointed MedPAC commissioner and has a great track record with RAND and so forth and various forms of healthcare policy-related research. So we've got some issues queued up for Cheryl, and I can assure you this is going to be an enlightening discussion. See everybody in 15 minutes, 1:15. Okay, welcome back, everyone. And we want to follow up the earlier part of our afternoon with what I think will be a very insightful discussion with Cheryl Damberg. For those that don't know Cheryl that well, she's based at RAND, and among other things at RAND, she's the PI and director of RAND's Center of Excellence in Health System Performance, which is funded by AHRQ. Among other things there, she's also project director for the Medicare Advantage and Prescription Drug Plan Star Ratings, of which many of you heard quite a bit. She's got like a quarter century of experience in areas of health, econ, and public policy, especially with regard to health system performance. She's got a lot of knowledge and expertise in the financing and delivery of care through the Medicare program and the commercial insurance market as well. So she's got public and private sector expertise. Among other things, with regard to value, she's an international expert in pay for performance and value-based payment. So again, US and international perspectives on that. And one of the things I didn't know and that caught my eye was that she was appointed a couple of years ago by the Comptroller General of the United States to serve on the Department of Labor's All Payer Claims Database Advisory Committee to provide advice on the standardized format for voluntary reporting of data by all the group health plans to the state all payer claims databases. We all know how important that is. It sounds kind of techie to a lot of people, but this is where we get the data, folks. And so I really admire her having a role in that as well. So Cheryl, you cover a lot of territory, and I think, for today's purposes, we want to focus largely, though not necessarily entirely, on addressing low value care, Cheryl. So just at a very high level, I know you've been listening a bit, but what's your sort of entry point on low value care? I want to drill down a little bit later on some of the strategies and some of the implications and so forth, but you have kind of a top line message for us vis-a-vis low value care?
It is still highly present in our health system, and I don't think we've figured out how to reduce it. And I think there are a number of interventions that are being tested, different strategies, but to date, I think those have had very modest effects. So big problem, need to fix it, and we're going to need lots of levers to, tamp down on that type of care.
Well, Cheryl, why do you think it is? We've been looking at low value care for quite some time, although not necessarily under that name. And we're wasting billions of dollars every year, many billions of dollars every year on low value care services. What is it about our healthcare system that makes this an ongoing uphill battle? Certainly we've had some successes. Absolutely. We got some tools and approaches, but from a system standpoint, why is it so hard to move this particular mountain?
That's a really great question. And I think there are a number of countervailing forces that really stand in the way of us making more progress in this front. First and foremost is our fee-for-service payment system, where providers, get paid more, the more services they deliver. And I think kind of hand in hand with that fee-for-service system, there's no what I call accountability. We have the tragedy of commons in play, where sort of nobody owns the problem and is working in a coordinated way to address the problem. I think you see more effort in that space around models where there is population-based accountability for not only quality, but costs. And so whether that's something that looks more like an ACO model or capitated type arrangements where people are equally focused on, the efficient delivery of healthcare and the consumption of resources used to deliver better health outcomes.
Do you think, Cheryl, that a high level approach here is going to be largely provider facing, patient facing, or both, or perhaps other? I mean, we've tried a bunch of ways, like we talk about nudges and so forth, putting stuff in the EHR. We talk about providing information to patients on more or less expensive drugs and so forth. Getting to reduce low value care, is there a particular strategy that faces in one direction or another?
Well, as I noted, I think this is going to be a multi-pronged approach, and that we're going to need strategies that come from all the different touch points, if you will. So certainly these different alternative payment models that hold providers accountable for both cost and quality are, extremely critical for making inroads on this front. I think a lot of the work that's been done, particularly through VBID, in terms of working toward value-based insurance design, paying for those things that actually deliver better value, better outcomes, and pricing those in a way that encourages delivery of the right care, I think is another important step. I do think that, the whole area of behavioral nudges is still relatively new and warrants continued exploration in terms of how to design those nudges and to put them in place. There are some complexities with doing that in the context of the EHR, given sort of the dynamic and ever-changing healthcare space in terms of, which drugs are used for which applications, The evidence keeps evolving. So there are some challenges with continuing to implement those in an EHR context and keep those up to date. But I do think in the context of those behavioral nudges in whether it's an EHR environment or somewhere in the practice environment, what you want is the default to be the right, effective form of treatment, also with cost implications wrapped around that. And so I think that health systems and provider practices have pretty successfully implemented some nudges in the EHR, such as purposeful ordering of different prescription drugs to promote the use of generics or first-line therapies. While they're still structured in a way that allows physicians to deviate, they tend to promote sort of higher prescribing in the places where you want them to. My team did some work exploring the use of behavioral nudges by health systems. They are using them, but they tend to be very limited in terms of their application. They are not widespread across health systems, and I think health systems could be doing more in that respect to drive value-based care.
Mm. So the nudges may be part of the toolkit, but not in and of themselves the answer.
Yeah, I think that's right. And then you had raised the question about the role of the consumer.
Yeah.
And I think that that's a challenging space, in part because I don't think consumers are well equipped to judge what is appropriate care. I think we already demand a lot of consumers in the health system to make sense of their benefits and different benefit designs. So again, I think anything in that consumer space needs to be constructed in ways that are simple for consumers to follow and to be able to take action on. Certainly, in terms of benefit design, differential pricing strategies, I think have been, somewhat successful. I think on the information front, it still remains challenging to get consumers to make use of this information. You just have to look at the Choosing Wisely campaign. I think they put together some interesting consumer materials, but I would say, 99.99% of the American population has never seen that information or would know what to do with it.
There is the consumer issue. And of course, in recent years, it's clear that consumers get input from so many directions. We've talked about provider fatigue, but consumer fatigue are just being lost in the pool of information, and disinformation and misinformation kind of makes this a little bit more difficult, I'd imagine.
Yeah, and I also, going back to the various countervailing forces, is I think consumers are always suspect that we're withholding care from them, that they think they need or that would be beneficial to them. And as I said, I think it's very hard for consumers to, judge what type of treatment is appropriate and when potentially treatment is not appropriate. I think that's a harder one for people to get their head wrapped around. I mean, I try to convey that to my husband routinely, and he has a PhD, and I'm still challenged in getting him educated on that front. So
yeah, you mentioned, by the way, Choosing Wisely, and we heard earlier that Choosing Wisely is being discontinued there. Is there sort of any downside impact of their kind of going away? And does that leave a gap in there insofar as the involvement or the challenges to the medical professional societies to identify these services?
Yeah, so I guess personally, I'm disappointed that they're stepping away from this. I do think it was helpful for the specialty societies to come together and agree on, what represents, best evidence-based care and what doesn't. And I think a lot of physicians look to their specialty societies for guidance. And I guess I would hope that there would be some continuation to, given the crisis in American healthcare in terms of what we can afford to spend and the types of outcomes we're achieving, and that we can actually do better. And I think that those physician specialty societies have a role to play in that. Overall, I think choosing wisely was not as effective as I think people might have imagined. And again, when I talked about consumers not knowing about it, I think most physicians did not even know about it. So I think we need to step back and say, how is it that we can better, communicate and educate physicians? And some of that's going to be done through what I call top-down mechanisms within health systems. They have folks who keep track of the evidence and, insert things into the electronic health records, such as these nudges, and to create what I call forcing functions to try to tamp down on some of this unwanted variation and low value.
It makes me wonder then, Cheryl, with regard to terminology, we've been using the term low value care. And, people kind of had a rough idea what choosing wisely meant, but does even the term low value care and trying to reduce low value care services sound threatening to anyone or nerdy to anyone, or is otherwise not a very effective way to brand this?
Oh, that's an interesting question.
Because you deal in a lot of policy stuff and laws and projects and so forth. They've all got names, they've all got brands. And I'm just wondering, like, does this play well?
Yeah, it's interesting. I have not heard people push back on the concept of low value care. I think everybody recognizes that there's waste in the US healthcare system. Certainly, no one wants to think that they are delivering wasteful care. So I think it's always that challenge of helping sort of frontline providers who are delivering care understand, where maybe how they're practicing isn't aligned with the current evidence, and where there's opportunities for improvement. So I think it's more on the how you communicate the need for change and getting them to change that's more important than what I'm going to call the terminology here.
Okay.
So I personally haven't encountered a problem with that terminology, but I would be interested in learning if others have.
It has arisen. Like, is this a whatever cool enough moniker, and has that been having to do with the issue? In a couple of our presentations earlier today, the matter of equity arose, and the extent to which populations that have traditionally been underserved or have been subject to widening disparities relate to, or get, I should say, a higher or lower proportion of low value care services. Do you think, Cheryl, that the currently at least prominent issue of equity is something that can be played appropriately or used appropriately or leveraged appropriately as a way to say, listen, here's yet another reason or line of thought for why we need to reduce low value care? Because in so many instances, these underserved populations, a lot of low value care is dumped on them and not enough high value care is offered them. So is there an angle there in the current environment to kind of try to leverage that argument a bit more?
Certainly, and I think some researchers have, through their studies, been spotlighting how, kind of ironically, as you note, certain populations are not receiving enough evidence-based care, but then are receiving too much low-value care. So I do certainly think it's one more piece in trying to, what I call, deliver optimal care, the best care for all populations. And particularly, for certain subgroups, it's going to mean, beefing up what we do on the evidence-based front ensuring that they get appropriate care, while also, being mindful that they're not receiving an inordinate amount of low value care. And I think what hasn't been unpacked in that research is why is that happening? I think many researchers have been trying for years to, identify the levers for why, let's say, Black individuals or people of Indigenous backgrounds aren't receiving appropriate care. And, there are a whole host of factors that influence that. They can be structural barriers, structural racism. It can be sort of access to providers in their community. It can be, the fact that they have access to lower quality providers. And so, I think we have to come at this from a number of different angles. And so, while I focus on one of these, such as lower quality providers, delivering less appropriate care, the question is it those same set of providers who are delivering more low value care? So as we think about how to target interventions to try to, move the dial and improve the delivery of care to all populations, where do we need to target, those interventions and try to, get physicians to, be in a better place to serve the populations that they are serving.
It just seems that a disproportionate number of people and families in these populations bring less to the table insofar as asking probing questions about whether or not I should have a service and so forth, and that they're seen as maybe easier marks or easier targets to kind of rack up charges. And so that's something we might want to be concerned about.
Yeah, although it's not totally clear to me that that's what's going on here. So I guess I'd need to either see what research has been done or what needs to be done. For many of these patient populations, they are seen by providers who disproportionately take Medicaid. And so it's not totally clear to me sort of what the financial incentive is. I mean, it could be there. I'm not suggesting it's not. My guess is, again, it's frontline physician understanding of what's optimal care, and then some of the barriers to getting people toward that optimal care. I mean, in terms of appropriate care. On the low value care front, again, it's this question of what are those underlying drivers that are creating a situation where more low value care is delivered to, certain subgroups. Like, why is that happening? And I don't think we really fully understand the why.
Yeah, still need to collect more information on that. I see that Louis Jacques wants to pose a question to you. Louis.
Yeah, to the extent that these are the same populations that are under-enrolled in clinical trials, how do we step back a minute and go, just because something is high value, low value, appropriate or not in the typical white male, because women are also under-enrolled clinical trial population, how do we know that that evidence generalizes to these other populations anyway? So I would suggest we might not even actually have enough evidence to identify high versus low, aside from just egregious examples of abuse in some of these subpopulations.
Good point, Cheryl.
Yeah, no, it's a good point. And I do think, the NIH has been trying to move at least the clinical trials it funds to requiring researchers to enroll more diverse populations. But I mean, if you look at sort of the current evidence and what it's built on, you're correct. It's built on sort of a narrow population subgroup. And, some of the evidence emerges in terms of effectiveness or ineffectiveness in some of the post trial information that's collected, but that information is collected in a very, what I call spotty, irregular way. And it's difficult to kind of inform frontline decision-making.
Got good response to that. Cheryl, I just want to, ultimately, I'm going to say this for a little later in our time. I'm going to ask about what MedPAC has to do with low value care services, and just kind of putting that sort of on deck in a few minutes. But right now, I just want to ask you about your connection to the all-payer claims databases and so forth. I know this is a bit of a switch here for a moment, but so much of what we're trying to understand can be derived in part from looking at these larger and larger databases, especially if we can link them. And so can you reflect just a bit on how these large claims databases might inform us about the sources and magnitudes of low value care services? Any thoughts along those lines?
Sure. I do think the all payer claims databases present really excellent opportunities to better measure and get a handle on where low value care is happening. And to do this in a multi-payer a way, because I think a lot of the studies that have been done and kind of our understanding has been constrained because we're only looking at narrow snapshots, whether it's looking at, say, one commercial plan's data or Medicare only. So I think it's helpful for measuring and spotlighting and continuing to bring a lot of attention to this issue. Because I think that's a critical piece in being able to move the dial, is keeping this in front of people and having them think hard about solutions. I would say this, and I think that this is also one of the challenges in making some inroads is, we have some measures of low value care. We clearly don't have probably as many measures as we need in this space to hold providers and health systems accountable. And in a number of cases, and if you looked at the Choosing Wisely measures, a lot of them relied on sort of detailed information that's in electronic health records, and not something that you can necessarily get out of claims data, which is what populates all payer claims databases. So, I'm going to be trying to look out I don't know, whether it's 10 years from now to say, if we want something that's an all-payer claims database, how do we think about that space a little bit differently so that the data is enriched with more clinical information to be able to dig deeper on questions like this one, to be able to better measure whether something truly is low value. And that requires clinical detail.
Can you hook up some of the APC data with EHR data?
That's, that would be nice. I think it's largely going to depend on the privacy people in the states who manage these systems, and then, the ability to link specific people from, say, an EHR in. Right. I think it's feasible. And different states have different rules about what types of identifiers they're collecting. But I think it's certainly worth testing that proposition.
Yeah, I think some of the large commercial payers are trying to do that, where they've got large data sets, but the APCDs have a lot of potential, it seems, for kind of identifying, where and to what extent low value care services rise, and to compare and contrast, it would seem very rich data source.
Yeah, and I think it's going to be critically important. You may know California is about to launch their all-payer claims database. It will be the biggest in the country, just given the size of the population here. But several states, Massachusetts, California is moving down this path of, creating spending targets, and, can be overall spending targets or targets directed at specific provider types like hospitals or specialty practices. And I think, providing information on where low value care is occurring, and how big the problem is, can help those provider entity types start focusing on where they're going to try to bend that cost curve, because they are going to be under pressure to do so based on those spending targets.
No kidding. Just, and this reminds us, our next speaker from Colorado is going to talk about their APCD and its role here. I see a lineup of Fendrick, Redberg, and Chernu all wanting to pose a question to you. So Mark, why don't you get us going? Start. What do you have?
I was trying to yield to Rita, but so Cheryl, you know, the reason why we invited you is that we get to, Mike and I get to ask you questions that we get asked and can't answer. So you and Allie and Aditi, who's on the call, could feel, so we've done a really good job of measuring low value care, even though it's a low bound. As Cliff says, it's billions of dollars, and you see the trends of most of those services, and we'll hear about this on the next speaker moving forward. I'm going to put you on the spot in the fact that we heard about a lot of potential solutions. And as I told you, this is a non-academic group that's actually looking for advice to be action-oriented. Yep. And you are aware that there is a part of the ACA that very few people know about, Section 4105, which gives the Secretary of Health and Human Services the option to not cover U.S. Preventive Services Task Force D-rated do not do services. And on behest of the previous Speaker of the House, your colleagues at UCLA RAND quantified 7 of the most common D-rated services at $5 billion over 10 years, real money, not including the cascades that people like David Kim has shown, that might be 6 to 1 or more for every dollar spent on the service itself. So is there any appetite among public payers that you know better, and maybe private payers, to basically say the same group that says things are so good they have to be free also mentions services that are so bad you shouldn't cover them at all, but you have a may as opposed to shall? Is this, to you and everyone on the call, Louis, is this something that's just going to perpetuate my aggravation? Or is there some reality to see a real solution to say DNR, not do not resuscitate, but do not reimburse these services that are designated to be at best not helpful, and in many cases harmful?
The options on the table there, Cheryl. Is anybody willing to pick it up?
Yeah, so Mark, unfortunately, I think you're going to be aggravated for some time to come. I have not heard people discussing that, but it doesn't mean we can't help kind of direct them in that space and to apply more pressure. And, you know, if anything, I would say, I think one of my big worries is we're moving stuff into the payment realm. If you look at sort of the latest Alzheimer's drug, you know, that has, you know, very minimal benefit, and yet it's going to cost taxpayers and consumers a lot of money. And so,
but I'll just interrupt you quickly. But that has at least a marginal. But I'm talking about, as Cliff has heard me say for 14 meetings, fruit below the ground. This is not cost effective. This is a benefit, but there are services that organizations have said now for decades is they do not work. The publicity around pseudoephedrine, right, got more attention than any of the Choosing Wisely recommendations, which is just, you know, aggravating to me. And I'm pleased to know you want to continue to aggravate me, but that's just great. Thank you.
Yeah, I mean, I would love to see it move in that direction. So I'll be right there with you advocating for it. But I've not heard any payer talk about doing that.
Well, we'd like to push it back on the table. And just wondering, if we spend a lot of money on the Alzheimer's drugs, how much we'll have left for the GLP-1 agonists? Somebody's going to run out of money pretty quickly. Rita Redberg is probably a good person to speak to unnecessary services, but what do you have, Rita?
Great discussion and great points, Mark and Cheryl. So sort of picking up on the Alzheimer's example, it illustrates sort of other ways I wonder if we could approach low value services. I mean, to me, I know Mark, I heard him say that he thinks there's a little benefit, and maybe there is, maybe there isn't. I don't think of a small change on a score of unclear clinical significance is a really meaningful benefit. So it certainly gets us back to FDA's standards of evidence of clinical benefit, because post-market surveillance basically doesn't exist in this country, and nothing changes no matter what we learn in the post-market. And that goes back to coverage. So firstly, I mean, I think if we could, and I don't know how feasible it is, but get rid of or certainly decrease our fee-for-service. Fee-for-service certainly incentivizes low-value care because we get paid handsomely for low-value care, and we've seen lots of examples of that this morning. And the other thing is concentrating on the harms. And again, Alzheimer's is a good example. I mean, people talked about that, small change in the difference in deterioration. I didn't hear a lot of discussion of the fact that 3 people died and who got the drug.
Yeah,
that's pretty bad to me. We just don't talk about harms. We tend to overestimate benefits and underestimate harms. And so I don't know but of course, again, the fee-for-service and Alzheimer's drug with our Part B, injectables and getting 6% of average sales prices, again, playing into all the wrong reasons that are going to incentivize use of a drug. And as I think Cliff said, is probably going to bankrupt, move Medicare to insolvency sooner. So I wonder about getting rid or less of fee-for-service and concentrating more on talking about harms.
What do you think, Cheryl?
Yeah, and I'm with you, Rita, on getting rid of fee-for-service. And definitely talking about harm, I think is important. Interestingly enough, so I have been involved in a randomized trial with colleagues over at UCLA who are testing out 3 behavioral nudges to try to reduce preoperative testing for people undergoing cataract surgery. And, they found some decline in the use of low-value services, but the one that seemed to have the most impact was talking about harm. So I found that was a really interesting finding. And I think if we could help people better understand that, it could make some inroads. I generally think people don't think about the potential harms of treatment. And as you say, they overvalue the positives. But I agree. I think fundamentally our financial incentives in our payment systems are creating a lot of problems. And, they certainly incentivize delivery of low value care with no kind of negative impacts. So for example, I've talked to lots of clinicians about, overuse of antibiotics. And, their comment is, yeah, we know we're not supposed to prescribe them, but, they only cost like $5. And so there's kind of no economic consequence either for the patient or the provider in that moment. So
you don't have to pay a lot to get harmed, right?
Right.
And to do public health harm as well. Good gosh.
Right. I mean, and they know the arguments around,
They do.
But it's sort of like, I don't know, it doesn't seem like it's worth the fight. But Mark, I really do like your idea of just not paying for certain things.
Yeah. Let's go to Mike Chernow next. Mike.
So now I have so many things to say. This was wonderful. And
we have limited time, so pick a few good ones. We have limited time.
I get to see Cheryl a bunch. So first, let me just say something quickly on alternative payment models. I don't think getting rid of fee-for-service versus keeping fee-for-service, I think that's a little too stark of a framing. There's a lot of things you can do, say shared savings program classic, where there's not full, you still have fee-for-service running underneath it, but you have a bunch of incentives on top in a range of ways. So it's really much more of a spectrum of payment, as opposed, you could have partial cap, but still have some fee-for-service. There's a bunch of things you could do in those models, but that wasn't why I raised my hand. I wanted to make a comment and then get Cheryl's reaction to the following point. One of the things that I find problematic in policy is that policies that clearly seem good get hung up in a lot of details, where the details don't always matter as much as moving in a general direction. I would pick the No Surprises Act is one where everyone knew we had to do, but just the implementation of how the negotiations went held it up for years, which seemed a little crazy. The one that I want to talk about now has to do with how granular you think we need to measure low value care. There's this notion that we'd like to get rid of low value care, but we don't have the data to get it exactly right in every exact case. And therefore, because we can't get it always right all the time, we just have to wait. And the hypothesis or the position that I would put on the table for your reaction to is, I think for
Can people hear Mike? I can't hear Mike.
Mike, we just lost you. Audio. He might try to come back without his video.
I know he has some challenges
he said that
from his house.
Can you hear me now?
Yes, we can, Mike. Finish up your question.
We'll see how this goes. My question, Cheryl, is how granular you think we need to be in terms of measurement in order to actually move forward.
What do you think, Cheryl?
So I think to continue to spotlight, apply pressure, make some of these policy shifts, I don't think you have to be granular. I think where granularity comes into play, and it doesn't have to be what I would call universal, is when you're trying to change frontline physician behavior. I think specific examples and showing them exactly where it's happening is needed sort of when you try to operationalize making the change. And I suspect, even without some of these measures, and Rita, I certainly welcome you jumping in here. I suspect that, within healthcare systems and provider groups, they already probably have a handle on where certain things are happening that don't need to happen, as well as where things should be happening that aren't. But Mike, I think you're right. I don't think that this has to be granular to affect policy and put some changes in place.
So let me just, I know you can't see me, but if I could just say one thing, I do think, for example, if you have targets, like you're providing 2% low value, average is 2%, and your targets are 4%, you're doing 3%, like in a Shawnee slide, the slide that was put up by someone earlier about the provider level average differences. I think it was in Minnesota, you could hold a group accountable for their average provision, even if you don't know the exact details of how much and specifically which one they're doing. But
thanks, Mike.
I think that's right. And I also think in the context of like performance measurement programs, these paper performance programs, I think even just selecting a handful of measures and maybe focusing them on the ones that Mark flagged about we shouldn't be paying for at all. Maybe having some laser focus there. So when employers are, negotiating contracts with payers and payers are negotiating contracts with the providers, maybe a handful of those very specific indicators could be useful.
Thanks, Cheryl. And thank you, Mike. Denise, we only have a few minutes. What briefly would you like to raise? Denise?
Yeah, no, try to do this quickly, just that this can be done. We've, through our low back pain implementation collaborative, we showed that we can pull all the stakeholders together and move things forward and reduce the low value care. So just wanted to remind everyone that we're out here and we're doing it and we're continuing to work in that direction.
Nicely noted in the chat box, I might add. I see Sarah just popped up. What do you have briefly? No, was it Sarah? Oh, now I see Aditi. Never mind. I thought I saw Sarah before. Aditi, what do you have?
Hi, thanks. Yeah, it's great to see you, Cheryl. I'm glad to slip in at the end. I just wanted to kind of point out to your earlier point, Cheryl, that we have recently did some work using our commercial claims data to look at the provision of low value care. And we found that, like 7 services accounted for about 70% of both use and spending on low value care. So I think this kind of idea about a really sort of targeted set of measures to focus on, that's sort of, there's evidence from, at least from our HCCI data, that, that might be a good entry point. And I just wonder if you think, looking at employers or insurers, or, trying to start with Medicare, like what is the right kind of entry point for policy to just target sort of a very specific set of measures, or as a providers?
Thanks,
Yeah.
Aditi.
So I think this, and hi Aditi, nice to see you. I think this kind of goes back to Mike's point, which is like if you look in California, the Integrated Healthcare Association holds, or the health plans that are part of that collaborative hold the provider groups accountable for, total cost of care. And that has prompted a number of the medical groups in the state to, whether they're using something like the Milliman waste calculator to run their data against it, and try to get a handle on sort of where they need to focus their energies. And I would say the conversation that I hear on the ground is one of, here's a really high cost, low value care service, but it happens very rarely. And then, you've got some of these like antibiotic prescribing that happen all the time and aren't very costly. And so I think the provider organizations are trying to figure out, like, with limited bandwidth to apply against this, where are they going to get the biggest bang for their buck? And so I do think that if you can get some of these, what I call macro incentives right, then the provider groups can do some of this deeper dig to figure out where to apply their attention and resources.
Right.
Yeah, and I think that makes a lot of sense. And we, just to follow up, that in our report, that's kind of the Venn diagram we looked at. It's like what are the top 10 use, which, as you said, are all like, pretty cheap. What are the top 10 in terms of spending, which are all pretty rare. But then, what are the kind of 7 that are on both of those lists?
Yeah.
Yeah. Thanks, Aditi. Just want to nearly slip in another question to which we referred before, Cheryl, and that is, what, if any, overlap do you see between your new role at MedPAC and low value care services? Is there any interaction or causality between what MedPAC does and can do and doing something about low value care?
Okay, well, so I need Mike Chernew to come on here and say that neither of us are speaking on behalf of MedPAC
right
in our presentation here. I think in the context of the work that MedPAC does, more broadly, there is a focus on trying to ensure Medicare beneficiaries have access to high quality care, and that, the Medicare program is not overpaying for services, and that they're paying to, the efficient delivery of care. And I think, this conversation around low value care gets at efficient delivery of care. And so whether it's the Medicare program, what's going on in the commercial insurance space or in Medicaid programs is no payer wants to be paying for, and the consumers who also have out-of-pockets that they have to come up with for care that's deemed unnecessary and adds to their spending. I think that MedPAC works to try to spotlight that for Congress, as well as the Medicare program and sort of the broader community at large, because a lot of what happens in the commercial space is following what the Medicare program does.
So a lot of downstream influence from that. Well, Cheryl, we have fired a whole bunch of questions at you from different directions for 45 minutes, and you fielded them so well. We really appreciate it. And I just think that helps to illustrate kind of your breadth of experience and expertise. We need that kind of breadth to understand and do something better about low value care services. And you've made a really strong contribution to our discussions today. We really appreciate your time. We really appreciate anyone's ability to take questions that weren't planned ahead of time. So job well done. Thanks,
Thank
Cheryl.
you so much. I really appreciated the opportunity to, speak with all of you today. And as I said at the outset, we need to keep up the drumbeat in this area.
We hear you. Well, we thank you for adding to the beat of the drums. Thank you very much, Cheryl.
All right.
Okay.
Thank you.
Thank you. Okay. We're next going to move to Colorado. And Kristen Paulson is here on behalf of the Center for Improving Value in Healthcare, CIVHC, to talk about addressing low value care from the standpoint of best practices and challenges. And her presentation is going to be very well grounded in what can be done under conditions where there's a good bit of support from multiple stakeholders and the expertise of someone like Kristen to help take the lead. So Kristen, very interested in seeing the best practices and challenges. You're on.
Thank you, Cliff. Thank you, everyone. Thank you for having me here. I'm going to go ahead and share my screen here so we can get presentation up. Sorry, I had it right here.
Okay.
There we go.
It's up.
It's up. Let's go to presenter mode and we can, oops, start from the beginning. How about that?
You're there. Good.
All right. Good afternoon, everyone. As Cliff mentioned, my name is Kristen Paulson. I'm the CEO at the Center for Improving Value in Healthcare, or CIVIC. We are going to go through a few things today. I'm going to spend just a little bit of time on the first two bullet points and hopefully spend the majority of our time on the second two bullet points and then in some related conversation around these issues. So going to introduce you to CIVIC and the Colorado APCD, talk a little bit about the trends and cost and low value care that we're seeing in Colorado, and then want to talk about what, from an actionable perspective, from what we're seeing on the ground, what we're seeing as best practices and the primary challenges in addressing low value care across our communities. And then I did bring 4 use cases to talk through about work that's happening right now in Colorado from different groups that are addressing low value care in different ways. So a little bit about CIVIC. I know that we have presented here before, so I am not going to belabor the point here too much. Our mission is to equip partners and communities in Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. Moving towards a vision of everyone having the opportunity to be healthy and having access to equitable, affordable, and high quality healthcare. We are an independent, objective 501c3 here in Colorado. We do have, by way of an agreement with the state, administration of the Colorado Alternate Claims Database, which we have built and overseen for the past 10 years. Just celebrated our 10-year anniversary this last fall. And we do our work in a few different ways. So we have a charge to make a lot of this data public and accessible to the people of Colorado. It's really seen as a resource of the people of Colorado. So we have extensive public data and reporting available through the various programs that we run at CIVIC with the Colorado APCD data. We also release non-public data to researchers, providers, systems, really across the state and across the country to help support advances in health and healthcare. And then we've really been building out our community services area, which is a group of team members which will do program evaluation, partner on novel research, and help create tools for our providers, for our systems to be able to really have success both within their systems and then also looking at community-focused services and beyond their immediate health system. This is just a brief snapshot of what we've got in the Colorado APCD as of today. We recently broke the 1 billion claim line mark just a couple months ago. We have approximately 70% of the covered lives in Colorado. And then we have also got an average annual population of approximately 5.5 million lives, representing over 48 commercial payers plus Medicaid and Medicare. We have a lot of trend information going back to 2012, 2013, and use that to sort of report out on the state of healthcare in Colorado. What's not in the Colorado APCD is what's not in most APCDs, which is the federal program information. So Veterans Administration, TRICARE, Indian Health Services, the Federal Employees Health Benefit Program, any uninsured or self-pay claims, and then about 60% of the ERISA-based self-insured employers within the state of Colorado. I think this group is probably very familiar with APCDs, but for those of you who may not be, there are about 19 active APCDs across the country. It's a very colorful map that we've put together, shows where we have active APCDs, where folks are implementing and building up the APCDs, where we have strong interest to expand, and then where we have voluntary efforts or no current interest to establish an APCD at this time. And if you have seen one APCD, unfortunately, at this time, you have seen one APCD. They all operate very differently under different state laws and state mandates. Colorado is very lucky in this respect. We do have a very strong state mandate that requires participation from all of our commercial payers in the state. And we also have a very broad charge to get the data out and make it actionable and bring it to the public eye for use. So in 2020, Doug McCarthy, who's a researcher at the Commonwealth Fund, put together a very comprehensive set of papers on all payer claims databases and the potential that they hold. And he identified 6 critical functions of an APCD that I've got here on this slide. I won't go through each one of them, but called out Civic and the Colorado APCD as being one of only 2 APCDs in the country, along with Maine, to be able to actually provide services in all 6 of these areas to support both our population and state policy perspectives and actions. So moving into some low value care trends that we're seeing here in Colorado. As is everywhere, we are seeing increases, steady increases in the cost of healthcare year over year. This is 2020 data. We found an anomaly in our 2021 data. So I went back to the 2020 data. Overall, 27% change from 2013. This is being primarily driven by pharmacy and prescription drugs, but not a small amount also coming from outpatient and provider payments over time. Interestingly, some of the efforts within the state of Colorado have kept hospital payments right around or actually below where they were back in 2013. This is something that the state has been working very hard on. But really that pharmaceutical spend is driving a lot of the increase in cost, especially in the last few years. So switching to low value care. So the following slides are coming from the 2021 data that we ran through the Milliman Health Waste Calculator. We've had that contract with Milliman for several years. As many of the folks here well know. In 2021, we had just shy of 2 million low-value care services across all of our payer types, resulting in around $134 million in excess spending. So you'll see here the top five low-value care practices, and it's inappropriate opioid prescriptions, screening for vitamin D deficiency, prostate cancer screening, eye disease imaging, and coronary angiography. These have been fairly consistent over the past several years, but we did notice there was a notable increase in the volume and in the spend associated with inappropriate opioid prescriptions over the pandemic. We've not gone into that with much detail, but we have noticed an increase sort of in the dramatic spike on the left hand of that graph. As this notes, the top 5 services account for 63% of total low value services spending. The top 10 services account for over 90% of low value services spending in Colorado. So here's a high level picture. This is all payer types across all regions in the state. You can see the total count of low value services, the total low value, the cost of those low value services, and the average cost per service. I will note that the average cost per service has actually decreased significantly over the last several years. It was actually closer to $100 per service and has dropped to $71 per service. I will note that the drop in 2021 to 7.1% only includes half of the Medicare fee-for-service data for the year. So it only includes data through June of 2021 for Medicare fee-for-service. So we're probably going to focus on this 2017 through 2020 timeframe. So we did see an initial drop from that 8.6%, but then holding fairly steady from 2018 through 2020. Now, there's a lot behind this sort of larger trend that I do want to take a look at, just so we can see where progress is being made on reducing low value care services as well as low value care spend. So here we have our 4 lines of business for 2021, with the exception of Medicare fee-for-service. I've grayed out the 2021 number and looked at 2020 alone, where we have a full year of data. So you'll see that in commercial, we had an initial fairly substantial drop in low value spending, but then have had another increase in 2021, which you could also see in the graph. The increase in cost is accompanied by a fairly dramatic increase in the number of low value services we saw among the commercial payers. We've seen a steady increase in the volume of low value services for Medicare Advantage, but not a concurrent increase in cost. And so that percent of spending number, we are showing that decrease from 8.9% in 2017 to 6.5% in 2021, which is kind of an interesting trend to see given the number of low value services among that population. With our Medicaid population, we do have a steady downward trajectory in the number and in the spend around low value care services, which is very encouraging. There's been a lot of work in our Medicaid agency to really address some of the low value care spending, but also to make sure that we are targeting high value care. I know those are two sides of basically the same coin, but there's really been a lot of emphasis on making sure we have the right kind of care for our Medicaid beneficiaries. And then finally, looking at Medicare fee-for-service, which has remained fairly steady. There's a spike in spending in 2020, likely associated with the pandemic, that did jump the percent of spending, but the number of services has remained fairly steady from 2017 through 2020. So we are seeing some sort of counter trends here where we've got Medicaid dropping, we have commercial increasing the spend, and so things are kind of canceling each other out, and there's a lot of there is some progress that's being made that may be masked by the high level all payer look at low value care spending and provision. So again, this is across all payer types. I will say that the top 5 are fairly consistent, even when you dive down into the different payer types. There are a couple things that flip-flop spaces, but those top 5 are fairly close to the top 5, whether it's Medicaid, commercial, Medicare, what have you. Again, at the top, we are seeing a huge spike in inappropriate opioid prescriptions. And number 2 would be the screening for vitamin D deficiency. I will say this was a new number 2 for us in 2021, this one popping to the top. A lot of that $12 million is actually being driven by Medicaid spend, interestingly. But this is the sort of distribution of our top 10 low value care practices. And then I found this table very interesting, and it's looking at the top 3 low value care services by payer. So you can kind of compare where those top services are for commercial, Medicaid, Medicare fee-for-service, Medicare Advantage, and then our CHIP Plus population. I think it's very interesting to note that we've got inappropriate opioid prescriptions as far and away number one for commercial, Medicaid, and Medicare Advantage, but it's not even showing up in the top 3 for Medicare fee-for-service. And there's a dramatic difference between the colorectal cancer screening low value spend between fee-for-service and Medicare Advantage. And again, keep in mind, this is only half of the year of Medicare fee-for-service spending, and it's a full year of spending for Medicare Advantage. So the discrepancy in those spend numbers between fee-for-service and MA are fairly notable. So yeah, happy to walk through this one in a little bit more detail. There's just a lot of interesting pieces here. So heading into reducing low value care. So what I do want to talk about briefly before we jump into the use cases is what we are seeing as far as commonalities across the various programs that are aiming to reduce low value care. So I've pulled together some of the common pieces of feedback that we hear from our partners across the state that are working to reduce low value care. Let me change slides here. So here are some best practices from the folks that are seeing success addressing low value care, gaining buy-in on the targets and the definitions of low value care, making sure that everyone who's involved in an initiative has a common definition and a common belief in the need to reduce that low value care, as well as where the target should be. We've seen a lot of fallout from folks who don't have common agreement on where we should be with this measure and if this measure does actually represent low value care. So when we have that buy-in and that consistent belief, that consistent definition agreement, things work much more smoothly. In best practices, we see a lot of measurement. This is where we come in with a lot of our partners, is helping with the measurement component, helping with that, bringing the cost component, helping to match with their EHR data to give a more comprehensive picture of where they're seeing outside, extra system use or inconsistencies, but really measuring throughout the entire process of an intervention, including that mid-process evaluation. So using those measurement pieces to see how successful things are halfway through a program, and being able to pivot and adjust as measures may indicate success or lack thereof. Engagement across the spectrum of care, so including the payer, the provider, and the consumer in that engagement in reducing low value care. There has been some significant employer engagement, but that employer engagement really has an impact at the payer level, in the structure of plan benefit design, in cost structures, things along those lines. And then at the consumer level, from an employee perspective, when we get to awareness or any kind of behavior incentive programs, but there is very little impact that an employer can have directly on the provider practice. They kind of need to rely on payers to be able to communicate that across. And then the final bullet point that is repeatedly brought to us is really the importance of education and putting in place incentives to sustain positive change. And that means education and incentives for both the providers and staff and for patients. A lot of these low value care pieces have trouble getting traction because of the lack of patient buy-in. And so that is a notable element of some of the more successful attempts that we've seen. Challenges, and I think some of these have been pretty continuous over the last several years. Defining what we mean by low value care and getting that buy-in is very challenging. There are a number of different countervailing opinions on this. So getting agreement around what is low value care is challenging. And getting providers and payers both to accept that definition of low value care and to be working towards a common goal. That can be very challenging. We are in the middle of dealing with this with one of our state agencies at the moment. And it gets very, very challenging when you're advocating low value care. It's something that they believe in and have for a long time is actually low value care. Making sure you have access to appropriate, timely, and actionable data. I think all three of those adjectives are fairly critical. This is where having multiple partners to be able to provide the data can come in very useful. Not providing sufficient incentives to reduce low value care at the provider or the consumer level to make sure that you have that ongoing effort and ongoing sort of reward for pursuing low value care or for pursuing higher value care. And then insufficient leverage to reduce the low value care. Consumers and employers many times don't have the leverage that they need to be able to reduce low value care or incentivize low value care on their own. And so really making sure that you've got partners across that healthcare continuum to support the leverage and the necessary buy-in for reducing low value care. So I've got 4 use cases I'm just going to give some high level information about, and then would really like to have a conversation and answer any questions that you guys have. I am taking a slightly broader look at low value care in these 4 use cases. These are not all based on the Milliman low value care choosing wisely guidelines. These are really efforts that have happened across the state in different sectors to improve the quality of care and to improve high value care while reducing costs and reducing inappropriate care at the same time. So this is from the Colorado Business Group on Health, the Colorado Purchasing Alliance, which is an alliance of employers that have come together to facilitate getting leverage to really make sure that they can negotiate with the payers and get a strong plan in place at the right price. So the goals here was to shift to high quality care and low cost providers to save employers money and to reduce the cost burden on employees and ensure that they're receiving those high value services. The challenges in this, they're dependent on carrier negotiations and benefit design, dependent on that sort of agreement. There are challenges identifying which providers are high quality, low cost. Data from the Colorado APCD can help dramatically in that way, but it's certainly not a silver bullet to identifying which providers should be targeted. And then it is hard to measure the direct impact or savings. This is a longer term effort that is going to require time for us to see if there actually is an impact on the kinds of services the involved employees are receiving and whether that is actually helping to drive down costs for employers and for the patients themselves. I will say that this effort has dropped premium prices for the involved employers over 50% in the last 2 years. So they are seeing an enormous decrease in premium cost, but there has not been enough time for us to assess what that means for actual patient care levels. There's also the challenge here with the volume at the individual employer level. These are small employers, typically under 500 employees. And so from a volume perspective, it does get a little challenging to be able to get into the nitty gritty of those measures to find out how things are performing at a specific employer level. Also, there's the fact that the low value care data, the low value care tools, especially through Milliman, are population level. And so getting those to apply down to the individual provider level is not really within the capabilities of that software and provides a bit of a challenge. So this second piece is an effort that came out of Children's Hospital of Colorado. I will say that we are seeing a lot of efforts in reducing low value care and improving high value care and care coordination from our Children's Hospital. The goal here was to understand care patterns and improve outcomes and costs for medically complex children, improving care, lowering costs, improving outcomes, understanding variation. And this was across the wide health system. So home health, mental health services, community-based providers, as well as hospital-based and outpatient-based services, and then standardizing care for these children. This was a very successful program. They had significantly increased outcomes and decreased costs for these children over a period of a couple of years. Challenges here that this was a very small and specific population. Replication, the applicability to a larger population is not proven and is going to be challenging. This was 100% provider driven. There were no payer incentives. There was no employer involvement. The patients bought in, but this was very much a provider-driven effort. And then finally, that this was really focused on larger care patterns. So this was focused on ED utilization, inpatient services utilization, community-based supports. This was not necessarily focused on changing the individual care practices of physicians at the direct care level. And so this was a larger behavioral intervention, but again, very successful. And this is a level we don't typically look at, but I think is really fascinating, is to look at what the state can actually do. What policy levers exist to decrease incentives and to decrease low-value care across the state. We have two separate policies in place right now with the state of Colorado to increase high-value primary care and to lower costs across the board. So the two efforts I'm speaking of are our primary care spending bill that establishes benchmarks and makes commercial carrier primary care spend part of a public report by named carrier. And so really getting it out there, what percentage of reimbursement is being dedicated to reimbursing for high quality, high value primary care. And that is part of the reporting that we at Civic do for the state of Colorado and work very closely with the Primary Care Commission. And then the second piece was introduced last year, and it's the Colorado option, which is a lower cost plan option that is being offered on the marketplace that has a decreased cost share for standard high value services. Obviously no cost for preventive care services, but really no cost for non-preventive primary care, as well as other areas of high value. The state policy focuses on regulatory benchmarks, not individual services, which means that we are seeing some varied application and varied approaches to these goals across the state. This doesn't directly benefit employers because this is through the marketplace. And it does rely on the carriers to incentivize providers. So there's no piece of the legislation that really delineates what incentive needs to be provided to the actual care practitioners, if any. And then we also have a longer term window that's going to evaluate effectiveness on this. And it's going to be slower to respond to any needed changes in policy. So definitely a different perspective, but one where we are seeing a better commitment to high value primary care from our carriers, and then are hoping to be able to match that with high value and low cost care at the individual enrollee level as well. And then finally, I wanted to mention, this is another project out of Children's Hospital, specifically coming out of their clinical effectiveness team. So Children's Hospital does have an 18-member clinical effectiveness team that basically finds areas where there's evidence that there's extensive low-value care happening, and then they launch a campaign to be able to intervene and create an environment where the higher value care is incentivized, higher value, lower cost care is incentivized. So they had two recent targets, axial imaging for abdominal pain, and then chest x-ray, viral panels, and bronchodilators for bronchiolitis. And their goal was really to reduce the use of these non-evidence-based or suboptimal care provisions and make sure that higher quality evidence-based interventions were put in place. They had universal health system buy-in and support. Part of that came through the support from their clinical effectiveness team, but they did have universal buy-in across the board, which was critical to the success of this undertaking. It was also sufficiently staffed. They invested in extensive and repeated provider and staff education that was reinforced over years. So this is a longer term intervention. They had eyes on sort of a multi-year intervention and made sure that that education was updated and continually provided to the providers and staff involved. And then there was also a patient education campaign through the providers, through the staff, and through things like posters and t-shirts. They had branded water bottles, but really improving the patient education so that the expectation of the patients would also be in line with the direction they were trying to take the provider practice. And then that was combined with frequent evaluation of effectiveness, positive reinforcement for gains made. And they are currently in the process of working with Civic to do a larger cost and outcome analysis to see the total impacts of this intervention. But I will say, and this is coming from a presentation from Dr. Lalit Bajaj at Children's Hospital, who headed up these interventions. This is the low value care sort of ranking from the primary or from the pediatric hospital information system. And this is, I believe, from, I've got my bar over the top of things here. This is from 2022. And we're seeing here Children's Hospital ranking as number 2 in terms of low quantities of low value care. And so we're seeing really the payoff from the work that they are doing. The work in those 2 areas started in 2018, 2019, and really started to show dramatic impacts starting in about 2020, and then through the pandemic, continuing the gains that they had made in that space. So really excited to be able to support some of these folks who are finding different mechanisms to address low value care and really improve the quality of the services they're providing. That's the end of my prepared comments. So if we can have a conversation, answer some questions and go from
Sure,
there.
Kristen. First of all, thank you. That was a rather comprehensive bit of coverage on the activities of Civic. A quick question though, what is Civic's relationship with its Colorado stakeholders? Do you get along with them? Do they get along with you? Do they look to you favorably overall?
Yeah, I think it's been a very conscientious effort of Civic over many years. That relationship has definitely ebbed and flowed. But over the past several years, Civic's involvement at the state level, at the health system level, at the carrier level has really pretty dramatically increased. And so we've got very positive relationships with our hospital systems, with our state agencies, and are getting a lot of support from that direction.
It's great to know that. It may ebb and flow a bit, but it seems like you're on pretty good footing now. I'm going to call on Lauren Vella and perhaps Randa Deaton as well. Lauren and Rand have had some comments regarding the role of employers, and what Lauren talked about is the employer push. Lauren, can we get you to comment on that? Perhaps Randa could reflect on it as well. Lauren?
Sure. I mean, I was just really agreeing with Mike Chernow that the employers are the ones in the driver's seat about getting TPAs to better administer these services. And until we get the employers to step up, I mean, I feel like the TPAs, specifically the BUCAs, they are doing very well now. Thank you very much. There's no reason for them to change the status quo. I, in my history, pushed back on them often on behalf of PBGH big employers. And then my time in the Walmart's benefit department pushed back continuously on them based on, just bringing questions to the forefront about low value care and other things that they should have been acting on, in my opinion, more than they were. And, the truth be told, if Walmart couldn't change them, who could? But why would they change? Because Walmart was not in a position to leave them, right? I mean, that's a challenge. So they're very happy with the status quo, and I'm not suggesting that leaving them is easy, and certainly for a company like Walmart it would not be easy, but there are employers out there who could leave a BUCA and go with an alternative plan, or as Randa said, work around them. Same thing. I mean, go, until they start losing business. And I don't mean just trading business back and forth amongst them. They do that all the time. It's almost like I used to have this picture of these, CEOs sitting in a room playing cards, and on the cards are Walmart and GM and Cisco and, GE, and they're just trading them around to each other. And that's fine until somebody else comes in the room with a different solution. That means that card is off the table. So I feel very strongly that I've seen it happen. I have seen the manipulation that is, that the employers are subjected to, frankly, by their TPAs. And I think that's a big part of our problem.
Randa, go ahead, Kristen.
I was just going to say, I couldn't agree more. That's one of the reasons why we the state of Colorado enabled the insurance alliances, these employer alliances, to give folks more leverage. Also, we have very, very little regulatory authority over our TPAs and ASOs in Colorado. There is no state agency that has regulatory oversight over the TPAs and ASOs. The other piece that we are seeing, which is concerning from our perspective, is that we've got a lot of these TPOs that are actually throwing up financial barriers to some of these employers getting their data into the APCD so that they can get transparency around what is actually happening with their employees. A lot of these folks are under ERISA, and so they're voluntary submitters to an APCD, but they depend on being able to get their data in the APCD. And when TPOs are throwing up, great, we'll do it, but it's going to be a $3 to $5 PMPM for you. That's financially a non-starter for some of these small businesses. And so that's where they're challenged too, because they can't get the measurement, they can't get the leverage to be able to approach the TPOs and make the argument that, listen, we're paying for way too much low value care, and you guys need to be putting, the right incentives in place and pushing. And there's just a number of different challenges in that space.
And they certainly do affect the ability and willingness of the employers to get engaged and kind of increase their leverage. Randa, did you have a comment from the PBGH angle as well?
Yeah, I would agree with Kristen. I will say I spent 25 years in HR and benefits. I am a big fan of APCDs. I think that all employers should share their data. I understand the barriers to it. I've shepherded data through, and it's incredibly difficult. But I definitely, if our members ask, I'm always supportive. And I do think the health plans have made it a lot easier than it used to be 10 years ago. So I think we also need to push our purchaser partners to, make sure that they're sharing data. What I will say is we are seeing the attestation that has to happen for gag clause removal by December 31st of 2023. We are seeing this hedging of, to attest or not to attest, because unfortunately not everyone's able to get their gag clauses removed. They're seeing like maybe so they're not able to get access to their data. So I think this is a huge issue. This is the part about going around. We need, large employers need and value their health plan partners, and they're incredibly important partners. But I think what we've seen is when purchasers can't get what they want, they've either done direct contracting or start moving around for that very reason, kind of what Lauren put in. But I do think employers would love to partner with their health plan partners to be able to do some of this innovative work, which is kind of why PBGH has really built these national standards. And Lauren and I just worked on a cool project on PBM standards. So a different group, PBM standards, which PBMs are pretty national, but how do you have national standards that are implemented at a local level, because healthcare is local and and so you have to transform care in a local market. But the plans as national plans with employers with national contracts, we have to kind of an alignment as purchasers on what our priorities are. So that's really been some of the work that we've been doing.
That is truly a big deal regarding what the employers can and can't do, the role that kind of the TPA is putting pressure on them in one direction, and how we can access the data. Point well taken. I'll note, by the way, Beth Bortz gave a 100% agreement on that issue as well from Virginia. Let's go to Mark Fendrick. Mark?
Kristen, thank you so much. It's what a perfect ending to this 14th meeting. I do want to raise one point, because some of us have been sitting through all 14. I know that's Beth and Cliff and Mike and I, is that every time someone comes in new and says there's a defining problem, and the motivation for this task force for the people who haven't been here through the 7 years is the alternative to lowering spending from low and no value care is either raising premiums on everyone, which seems to be a non-starter, or raising cost sharing for people who need care, which Mike and I call a tax on the sick. And given that the sky is falling with all the benefit consultants who we all love projecting 8, 9, 10% cost increases across the board for various reasons, we have to incur those in either premiums, cost sharing, or reduction of services, which is why Beth Boyden-Seiler and Peter Newman and others, we've been working really hard on this task force to define a list of services that go beyond the 40 plus that you use in the health waste calculator to the very, very few that we call no value care that have first evidence that they're of no value. That's an issue. But second, no patient demand, which often overcomes clinicians' unwillingness to, say, prescribe an antibiotic, which is clearly unnecessary. And the third, which I align very closely with my colleague Lauren Vella, is there's no clinical nuance. So a cervical cytology in a woman under the age of 21, I would argue even the most unsophisticated employer plan would know a patient's age, right? So, and I see, Beth, employers are very, very risk averse, but we have to start somewhere. We have our top 5, Cliff, that were the no-brainers 7 years ago. We have a new list of no-brainers, and I don't think it's defining them. I don't think it's finding it from claims, as Aditi Sen has shown. I think it's just courage. And I think it's some of the issues that Mike will say, I'm going to be gone for the day. And why this group and gathering is so important to me is because if we don't do it, no one will. So with that, Cliff, I'm not going to thank you again. I'm going to thank you. We both forgot to point out that we loved that this was the first task force meeting with all female presenters, which followed the VBID summit last fall. So that's probably why it's so damn good. But with that, I thank all the speakers who are still left and certainly the attendees, and Cliff, for your superb moderating.
Thank you, Mark. I just wanted to give Kristen just an opportunity for any final comments with regard to what she said or didn't say, or what she heard from any of these responses. Final comments, Kristen?
I think there's a lot of folks on the same page as far as this group here, but this also echoes to the work that we're seeing throughout Colorado. We're seeing increased engagement from employers. Civic has been very closely engaged. The Colorado Business Group on Health, which is one of the use cases, as Randa mentioned, has since closed its doors and sort of rolled its members into the Purchasers Business Group on Health. But we've been very involved with those purchasing alliances from the get-go, from day one. And that measurement is critical to the success that they're having. All of them are using our data, using our reporting to be able to get that leverage and give those employers that ability. I think we may be a little unique in Colorado in that at least our smaller employers, a lot of them are not having that resistance to getting their data in. It really is the obstacles that are being kind of raised by the TPAs and ASOs that are preventing more small employers from accessing the benefits of something like an APCD. And so that's really, I think, an area that we're going to have to address nationally. I think as APCDs grow in popularity and grow in capability, we're currently working on a project with Virginia and with Maine to try to bring together multi-state data to be able to start leveraging the capabilities of these states that have well-established APCDs so that we can better serve the needs of some of these large employers. That's one of the key use cases is how can we bring together the data that the larger employers need to be convinced that this is a place to invest in. This is a place to really put the data so that you can benefit from the structures that are in place. So we're seeing some progress, but I think there's a lot more movement that we're going to need to be able to really shift the dial on low value care.
Thanks very much, Kristen. I must say that as Mark was talking about having had 14 of our meetings, one of the things that is really clear now, and I've got to say, Kristen, as well as anybody you've outlined it, is where exactly are the hurdles and the barriers? Where exactly are there the professional and societal behavioral responses that favor or disfavor making this happen? And I think that your case studies, I really love those 4 case studies that you presented, and certainly that final bar chart that really shows kind of comparative performance. That's rather persuasive. That's the kind of bar chart you want to show to a lot of people. So I really do appreciate that. In a moment, I'm going to hand it over to Mike Chernew for some final comments. But before I do that, I wanted to give anyone else present now who has any final comments or observations they'd like to make with regard to what they've heard, any reactions. any final kind of suggestions or observations anyone wants to make here. And I'll call on anyone who wants to raise their hand, or sometimes I just call on people in general if they have something to say. I'll tell you what I'm going to do. Mike Ingham, you're kind of new to this, representing Janssen out of J&J. And gosh, you know, Janssen and J&J are always in the news one way or another. I think at least one of your drugs is one of the top 10 that the price negotiation folks are going to be scrutinizing. And you certainly, the company wide, you span drugs, but you know, biologics, devices, and so forth. You're getting into digital and AI. Any sort of comments, reactions to what you heard today?
No, I think what I really liked is that I really like this sort of movement to the discussion about implementation and how you can actually do it. What are the barriers? How do we actually act on this? Because I think, you know, like we saw earlier on, there's a lot of publications now talking about low value care, value-based care. But then how do you actually do it? How do you do it in practice? So I just, that's what I really took away from today, was just this multiple of discussions, which I really enjoyed, about sort of different case studies of how you could actually do this, and maybe what work we still need to have to do to be able to do it. And we support that.
Got it. Thank you very much. Aditi, can I pick on you next? Do you mind? Aditi, Sen, comments, final, anything else you might have?
Yeah, no, I think that, you know, at HCCI, we do a lot of, you know, our kind of main business is data work, but it's, you know, data to inform change and policy. And I think, you know, this is, I think, my second or third meeting. And, you know, what I always really appreciate is the focus on translating all this data and findings into action, and kind of thinking about it from not just one policy or one stakeholder, but sort of the whole continuum, and where might we be able to use the data that we already have and kind of what we already know and build on that, but also sort of identify multiple entry points for action. So yeah, no, I think it's great.
Thank you very much, Aditi. Okay, any other final comments? I'm about to turn it over to Mike Chernew. Going once, twice. Mike, I ate into your time just a little bit, but I'm glad to turn it over to you. And Mike, in particular, I think everyone here would appreciate your reflection on where we go next with this. Like I just mentioned a few moments ago, Kristen's presentation, frankly, all the ones we heard today hit on issues of how important this is, but also each one revealed how hard it is to make this happen, whether it's regard to patient or provider inertia, who's getting paid, whose turf is being threatened, and so forth, the use of data or the access to data. There are a lot of things that sort of get in the way of doing the right thing. We see some successes, but Mike, looking ahead, where do you think we need to go next? Mike Chernew.
Yeah, first of all, I apologize if my internet freezes. I may go off video, but in any case, I think that Mike Ingram was spot on in what he said, which is one needs to think through sort of the action model. And per the comments that Lauren Vella and Rhonda said earlier, I do think it starts at the top of the food chain with the purchasers. And the issue is there's a lot, it's like one of those pachinko boards. There's a lot of ways you can fall out before getting to the bottom. And I do think that part of the problem is we rely on people's goodwill or knowledge. Let's just tell them and they won't do it. And that tends to run into both practical problems. People are doing a lot, they're very busy, things of that nature. It runs into business model problems. So I think what was nice about the meeting today, we really did span the entire chain of activities. We started the day with some study on breast cancer and research there and what was happening. It was very clear that the clinical research is important. And I think that's the foundation of understanding value, is that's what clinical research. And then you realize, you need to change people at the bedside. The behavior at the bedside is actually what care people get. But the behavior at the bedside depends on the incentives, and it depends on the system, as Anna spoke of the vertical integration and how that changes the system and how all that works, in addition to the pricing problems associated with integration. So we have to think about that, but the system responds to the incentives they get, which comes from the carriers, and the carriers have their own data. And of course, how the carriers behave depends on the employers, and that gets filtered through the benefit consultants. And we have this very complicated ecosystem. Again, I do think we're going to continue to figure out ways of trying to get the employers to hold the carriers accountable for holding the systems accountable for the care that's delivered at the bedside. And that's a That's a long chain. That makes it hard. I have the exact same reaction Mike just had, by the way. I'm glad you're on camera, Mike. If we were in person, if it was easy, we would have stopped after 2 meetings. So one place to go is to think through that whole exchange better. I was the chair of the Harvard Benefits Committee for a long time, and I can tell you the RFP process was the core place in which we could influence the carriers, and we were unbelievably timid in what we did for a bunch of reasons. I actually think we could do better, and there's a bunch of people that have been here today. The example in Minnesota was, I hadn't heard about it before from Josh, was unbelievably, I've sent him several chats to learn more, unbelievable encouraging. I actually think the messages from Civic were really useful. You could see some real action when they work. So it's not, it can't be done. It just requires some focusing, and as spending rises and as there's high value services that we are going to want to spend money on, we're going to need to do a better job on both price and reduction of low value care. There's one other place I'm going to highlight, because I'm saying this because I'd like to hear from people if they would be interested in this for the next meeting as we plan the agenda. I've been increasingly doing work in the area of artificial intelligence. And so there's real interest, I think, in how artificial intelligence and algorithms can be used to potentially get rid of low value care in a much more nuanced way, particularly, for example, imaging services. There's a whole bunch of stuff you can do now to get, there's a bunch of cardiac ones, a bunch of derm ones, I think that's ophthalmology. I'm an economist. I can say cholecystectomy. Anyway, the point is there's a ton of these examples where we might be able to use AI algorithms to help care at the bedside. And the question, of course, is that sounds wonderful. The fiscal consequences of AI algorithms, particularly if we pay for them, could be enormously detrimental. And so the policy around how to do this, we were talking before about alternative payment models, how that plays out, and in Cheryl's conversation that came up, that will be important. And so I think we might spend I suspect next time we'll have at least one session on the role of AI in low value care. And I hope to have another session to talk about employers. And again, another question, which has been very clear to me, and it's some of the most innovative players on the employer side turn out to be the states as purchasers.
Yeah.
And and I think that's for a bunch of reasons. It'd be interesting to discuss, but I think really pushing on the state level action. I know if you just follow the meeting today, we had California. Cheryl mentioned California and what they're doing. We had Colorado, obviously. Beth Bortz has been ahead of all of the people in Virginia. She was, at the very beginning. The Minnesota example comes to mind. In the past, we've actually had coalitions. We had Oregon for a while, Utah, Massachusetts has cost targets. Cheryl mentioned cost targets, what we're doing in Massachusetts. I know the Massachusetts folks. So I do think that going forward, leveraging the states not only to act to support stakeholders in their states, but also as purchasers to be more aggressive and lead the way on developing sort of cutting edge contracting. We tried to do this at Low Value Care Task Force, maybe 1 or 2. We had some tools. I actually think we may have been ahead of our time, and we may have to come back to do that and to think through that more. So those are the areas that I'm thinking about. The speakers across the board today were excellent. I could not be happier with how the day went and how the questions were and the engagement we got from people. The moderator is always spectacular. It's amazing how good a job you do, Cliff. You don't age and you don't tire. It's a weird thing, but anyway, in any case, thank you, Cliff. And of course, let me thank Mark for doing 98% of the sort of broad thinking. And of course, Susan Lynn and Jordan and the rest of the team for doing 100% of the actual really hard work. We could not do it without them and putting this together. They do a great job. I'm going through my thanks now in case it's not clear. I want to thank the sponsors, which is J&J. I see Mike. I don't know if Allie's here from Pharma. I'm sorry, I can't see everyone on the screen, but in any case, thanks to Pharma for this. I do think it continually demonstrates an interest in making the healthcare system better, as opposed, we understand that drugs are important. Anyone who's had a COVID vaccine understands that there's a lot of other things coming down where they're important. But I think apart from just producing products that end up being very important. Helping the system itself be better is important. And so I really do want to thank J&J and Pharma for their contributions to make all of this possible. And last, I want to thank all of you. If you know people that aren't here still, reach out to them and thank them again, because it really is a top-notch group of people that come to these meetings. And it's really been a privilege to get to hear the speakers speak and the participants add their questions. So I really am really happy with how today went. I mentioned some of the topics we're considering for our spring meeting. Put it on your calendar, April 24th, 2024. That'll be the day. Oh, Lauren mentioned school districts. Agree completely. So in any case, we will be back. We will see you in April. I hope everybody has healthy, productive, and great experiences to share with us then. But it's nice to see so many folks interested in making sure the healthcare system is not delivering care that people should not get and is delivering care that they should. So again, thank you. Mark, you want to add anything? Because else I'm saying goodbye.
Me too. Have a good rest of your day, everybody. Go Phillies.
Yeah, thanks.
Thanks, everybody. Thanks all.